Good morning. Just a few housekeeping reminders. In-person attendees need to sign the sign-in sheet, so if you have not done that yet, make sure when we have a break to go sign the sign-in sheet this morning. A reminder that all virtual participants are set to mute. If you have a question, please type it in the Q&A box, and we will have the speaker address it at the end of the session if time permits. If not, we will collect answers from the speaker and distribute the response to all the registrants. All presentations will be available to view on demand online for 1 month following the conference. Those are at LMU-DCOM. Attestation forms needed to claim CME credit may be completed by attendees on Sunday in person at the close of the conference. These forms will be distributed to in-person attendees and are available online for the virtual attendees. PDFs of today's presentations are at LMU-DCOM, and disclosures for all speakers are available for inspection at the office of LMU-DCOM Director of Alumni Services. It is my pleasure to introduce Dr. Jeffrey Ham. He is currently an assistant professor of family medicine and community medicine for Wake Forest Medical School in Charlotte, North Carolina. He's employed by Atrium Wake Forest Baptist and works 100% of the time in musculoskeletal medicine. Dr. Ham received his Doctor of Osteopathic Medicine degree from LMU-DCOM in 2015. His affiliated organizations include Atrium Health, Wake Forest Medical School, University of North Carolina at Charlotte, Queen's University at Charlotte, AMSSM, and NCAFP. Please help me welcome Dr. Ham.
Good morning. Thank you, everybody, for being here so early today. Let's see. How does it? There we go. Perfect. All right. So as Dana mentioned, my name is Dr. Ham. Thank you, Dana, for the invite to talk today, and thank you, LMU, as well. Today, what we're going to do is an overview of musculoskeletal medicine for primary care. So things that I would like for you to take from today is recognize certain types of tendon disorders and tendon disuse disorders, and learn what type of treatment modality would be the most appropriate for those types of disorders. Differentiate different types of subtypes as well as the healing phases for tendon issues. Compare treatment options, which can include conservative, biologic, as well as procedural treatment. We're going to review management of frozen shoulder, ankle fractures, as well as femoral acetabular impingement. And then we're going to learn some about the musculoskeletal exam. So we're going to start with a question. A 45-year-old right-handed tennis player presents with lateral elbow pain that has progressively worsened over the past 6 months. The pain is localized over the lateral epicondyle and worsens with gripping or lifting the object, especially with the arm in extended position. On physical exam, there is tenderness over the common extensor tendon origin and pain with resisted wrist extension. Radiographs are unremarkable. You recommend conservative treatment. Which of the following has the most evidence-based support for improving the tendon structure and reducing the pain in this condition? A, corticosteroid injection into the tendon, immobilization with a wrist brace for 6 weeks. B, eccentric exercises for extensor tendon, or D, therapeutic ultrasound. All right. So we're going to learn today why the answer is C and how we're going to do eccentric exercises for this condition. So the word tendinopathy is a spectrum of certain types of tendon issues. We used to call everything tendinitis, rotator cuff tendinitis, greater trochanteric bursitis. But if you look at a pathological disease process, what we know is that these all lie on a spectrum. So you can have acute tendinitis, where there's inflammation of the tendon itself. You can have tenosynovitis, which think of that as more of inflammation of the sheath surrounding the tendon. That's when you look at your de Quervain veins or trigger fingers, those types of things. You can have tendinosis, which means thickening of the tendon. The way I talk to patients about tendinosis is I want them to imagine a rope. And you take that rope and you put it in the sun for a couple of days, and what will happen is that rope will start to thicken and it will start to fray. And as it does that, it loses some of its elastic properties, it loses some of its strength, and that's what's happening with chronic tendon disorders. You can have calcium deposits in the tendon itself, especially in the shoulder, especially in the hip. That's called calcific tendinitis. And then you can have degenerative tears, where you can have actually the rope is starting to fray so much that you're having tearing of the tendon partially. So when you think of treatment for tendon disorders, we need to think about the pathophysiology. So normal tendon is type 1 collagen. It has a strong proteoglycan matrix, and it has very few fibroblasts. In chronic tendon issues or tendinopathy, it's less of type 1 collagen and more of that type 3 collagen. You have increased blood vessels, you have increased neoneurogenesis, and you have more of a disorganization of the extracellular matrix. So what you can see on the right side of the screen is, in the green is what we want. We want to go exercise, we want to get stronger, we want to improve our function. However, if the load is too much, instead of the adaptation and strengthening, you'll actually move into more of a disorganization or disrepair. And that's when you start to see your reactive tendinopathies, your tendon disrepair, and your degenerative tendons. So the three phases of healing of a tendon, you have your acute phase of healing, that's your inflammatory phase, that's typically over the course of the first 48 hours. When you have that, that's when your neutrophils are going to be there, that's when your macrophages are going to be there, and that's when your tendon stem cells are going to be there. The role of that phase is to try to clean out as best you can the acute damage, and for the tendon cells to start to become tenocytes. As you move past that, you move into your proliferative phase, and in the proliferative phase, you're going to start to see the tenocytes try to put down new tendon. You're going to start to see the macrophages start to continue to clean out the debris, and then you're going to move into your remodeling phase. The remodeling phase can take up to a year, and that's when you see your adult cells back in the area. With tendon disorders and tendon issues, we have things that we can control, and we have things that we can't control. And those are your risk factors in regards to tendon issues. Things that you can't control your alignment, you can't control your weakness, you can't control your age. Females are more common for chronic tendinopathies. The disease processes that we see aligned with tendon pathology would be things like diabetes, dyslipidemia, obesity, as well as family history. And then with things that we can control is we can control how much your athlete or your patient is exercising. We can control the technique. We can control the equipment. And we can control what medications they're taking. So things like fluoroquinolone, statin medications, hormone replacement therapy, all those have been shown to increase the risk of chronic tendon disorders. So these are not a complete list, but these are things that we typically see that involve tendinopathic changes in the tendon. You have your rotator cuff disease, rotator cuff impingement syndrome, rotator cuff bursitis. You have your lateral and medial tendon epicondylosis. These are your golfer's elbow, your tennis elbow. You can see tendon issues with the biceps tendon, the triceps tendon. You can see de Quervain's, what's called tenosynovitis, which you typically see in new moms or new grandmothers, typically in the first compartment of the wrist over here, worse with gripping. And then you have what's called greater trochanteric pain syndrome, which is the new name for greater trochanteric bursitis. We call it greater trochanteric pain syndrome because there's not really bursitis in the area most typically. It's not an inflammatory process, it's more of a degenerative process. You can also see it in your knee tendons, your quadriceps, your patella, and then posterior tibial, fibularis, and the Achilles. When working up these patients, x-ray typically not necessary in the beginning. This is a diagnosis made by your history, and this is a diagnosis made on your palpation skills. Typically when I'm getting an x-ray, I'm wanting to rule out some type of bony pathology. I'm wanting to rule out, is this arthritis? Is this calcific tendonitis? And a lot of times, to be honest, the reason I order an x-ray is so later I can order an MRI. Most insurance companies are going to require an x-ray before they'll approve an MRI of a joint. Then you look at MRI versus ultrasound. Ultrasound is actually superior in most studies that you see, and it's cheaper. The problem with ultrasound is that ultrasound is incredibly operator dependent, and it really depends on how good your ultrasonographer is that day. So on the top of the screen, that is a thickening of the tendon that you'll see on ultrasound. That's that rope that's been sitting out for a couple of days. It's starting to show that widening. If someone would have put on something called a color Doppler, you would see increased blood flow to the area. And in the bottom of the screen, that is a tendon that has had so much damage that you're starting to see tearing of the tendon. You're starting to see what's called a split tear. So it's not a complete tear, but you're starting to see disorganization to that point. So treatment, several things that we're going to talk about. We're going to talk about, just education you can provide to the patient as far as activity restrictions, activity limitations. We're going to talk about exercise. We're going to talk about non-steroidal anti-inflammatories and corticosteroid injections. I kind of lumped them together because the evidence is about the same for both, to be honest. We're going to talk a little bit about a new technology called shockwave therapy, and then a novel technology called platelet-rich plasma, and device and needle tenotomy devices. So I think the most important thing you guys can take away from this lecture in regards to tendinopathic changes is that RICE is out. We do not want to rest someone when they have chronic tendon issues, because what happens when we rest is it actually increases scar tissue formation and can make it harder for them to return. The tendon actually needs load, like we saw on the previous slide. We need that load to help with organization of the tendon itself. So a new mnemonic that you can use if you want to would be police. We want to protect the tendon. So if you feel like they need a boot for a short period of time, that's appropriate. If you feel like they need a brace or a strap, that's appropriate. We want to operative load the tendon. What does that mean? It means anything that they're able to do, I want them doing it. And that can be range of motion exercises, that can be something called isometric exercises, where you're not actually moving the joint, you're just kind of contracting against resistance. And then we're going to talk a little bit about eccentric exercises, which on all of your test questions for the rest of your life, that's going to be the answer, eccentric exercises. ICE is always your friend. ICE is a very good adjunct, especially in the acute phase. Compression and elevation are still the goal. So what are some lifestyle modifications that you can talk to your patients about? If your patient comes in with rotator cuff disease, or they come in with biceps tendon disease, then a lot of times what I'll tell them is you're okay doing anything from 90 degrees down. If it's above 90 degrees, that puts them more into that impingement window, and that's going to cause irritation to them. So what I typically say is no overhead stuff, everything 90 degrees down. If you're talking about tennis elbow or lateral epicondylosis, I'm going to talk to them about a wider grip. When you have a wider grip, what it does is it takes the load off the wrist itself, and you don't have to put as much grip force in. If you're talking to a tennis player, sometimes we'll do softer strings. What that means is when the ball actually hits the racket, the string will take more of the load and not that outside elbow. And then, if it's a normal, non-athletic patient, I'm telling them, I want them to lift everything with their palm up. Because when you lift things with your palm up, you're loading the inside elbow. When you lift things with your palm down, you're loading that lateral epicondyle. So if they're picking up the groceries, if they're picking up the milk, if they're doing anything at home, everything palm up. Vice versa for the medial epicondyle. We want to lift everything with the palm down. And then with the posterior tibial tendon, with the Achilles tendon, and with plantar fasciitis, you really want to talk to them about not going barefooted. A lot of those conditions are due to being pes planus or flat-footed, so you want to make sure that they're wearing shoes at all times. So we're going to look at some DME. This would be an example of a lateral epicondyle or medial epicondyle strap. The goal of this strap is to take the pressure off of the bone itself and put it more into the muscle belly of the tendon. A lot of patients will do this incorrectly, and they'll actually put the strap directly over the bone itself, and it makes it more uncomfortable for them. A good rule of thumb that I use is I go 3-finger breaths, and then what that does is that puts it more on the muscle belly itself. Muscle belly has good blood supply, it can take that load. You can do this for lateral epicondyle as well as the medial epicondyle. This is an example of those lateral and medial epicondyle by putting all the tension in the brace itself. So if you have someone who does a lot of labor, if you have someone who works a lot with their hands, it'll put them in that position and they can continue to do their job without having pain at that time. This is a thumb spica brace. The goal of a thumb spica brace is to shut down the thumb. They're still able to bend the distal part of the thumb, but it locks up the CMC joint mainly. The role of the thumb spica brace for tendon issues would be someone with de Quervain's. So if you have a new mom, new grandmother, and they're chronically picking up the baby, they can wear this while they're picking up the baby, and that way they won't have pain, and they'll allow us to do the other things we want to do. This is an example of a quadricep tendon strap. If you ever watch an NBA basketball game, you're going to see a lot of quadricep tendon straps, patella tendon straps. The role of them is just like with the counterforce strap at the elbow. We're just trying to take the tension off. With the knee, the thing about the knee, the patella tendon, is the least vascularized area of the patella tendon is the proximal aspect of the patella tendon, so right under the patella itself. So what I'll tell them to do is put the patella tendon strap into the mid part of the patella tendon to take that pressure off that spot. And then if you're struggling with someone or someone's struggling with Achilles issues, I'll put them in a heel lift. What a heel lift does is it shortens that Achilles tendon and takes some of the load off that Achilles tendon for them. Now we're going to get into exercise, and like I said, any amount of exercise is better than no exercise alone. What we're really trying to prevent is shutting them down completely. If you look at most of the studies from the 90s, 2000s, 2010s, what you're going to see is that eccentric exercise, which means that progressive elongation of the tendon against resistance, is superior than any other type of exercise. However, if you look at more recent studies, they are showing that heavy, slow, what's called concentric exercise, where you're contracting and it's shortening, is non-inferior. So like I said, any amount of exercise is better than none. However, if you do have a test question on it, the answer is still eccentric exercise. Corticosteroid injections have fallen out of favor a lot with sports medicine, and the main reason for that is corticosteroid injections have been demonstrated to be incredibly tenotoxic, so they're actually toxic to the tendon cells themselves and can make that disorganization a lot worse. What these studies do show is that corticosteroid injections are incredibly effective for approximately 1 month. So they're a very good anti-inflammatory. They decrease pain for approximately 1 month in most patients. My role for corticosteroid injection is I use them as a bridge to get someone into the exercises. So if you have a patient and they have horrible rotator cuff pain, they can't sleep on it at night, they can't raise their arm, sometimes I will offer them a steroid injection, calm everything down, but I let them know this isn't fixing anything. This is not the treatment. The true treatment is either physical therapy or the home exercise program we'll design for them. So that's what we're looking for there with corticosteroid injections. Shockwave therapy is a new modality, and it is where it sends extracorporeal shock waves into the tendon. And what those do is they stimulate neuropeptides, they stimulate nitric oxide, they stimulate toll-like receptor 3, and then they increase your macrophages. The role of shockwave is to basically increase the blood flow to the area to allow the body to naturally heal itself faster by increasing the macrophage count. At this point, shockwave therapy is not currently covered by commercial insurance. It's $100 typically per session, and most studies show that you need 3 to 5 sessions. So it is an adjunct, but the true treatment is still the exercise. Platelet-rich plasma. Platelet-rich plasma was originally introduced in the dentist literature to increase blood flow to area to help with healing. What we do is we take the patient's whole blood, we put the whole blood in a centrifuge, and it spins. And as it spins, it separates based on weight. And then we pull the platelets out and basically inject those into the tendons themselves. We do that because platelets contain millions of growth factors, and when we inject growth factors into the tendon, they degranulate, release those growth factors, and they increase the blood flow to the area and basically stimulate rehealing. The way I describe it to the patient is it's like the Batman signal. We put it into the tendon, Batman signal goes up, all the cells come to the area and help with healing. The literature behind platelet-rich plasma is a mixed bag. Most of the literature done initially is going to show that it was not a good idea to do that. However, if you look at the recent literature where they're looking more at the actual platelet count and not just the fact that they were using platelets themselves, the platelet-rich plasma has been shown to be superior to corticosteroid injections at 3, 6, and 9 months. So it's more of a long-term gain, but it is starting to show more signs to point towards evidence-based. The treatment dose that you're looking for is roughly 1 million platelets, or at least 4 times the patient's normal average. And then the last device we're going to talk about is what's called a needle tenotomy. There's several brand names on the market, but basically what they do is they either use sound waves, they use oscillation, or they use water, normal saline, and they're stripping the brittle tissue off the tendon. These are covered by insurance, and they are incredibly evidence-based. The problem most patients have with this is that insurance requires this to be done at an ambulatory surgery center, so a lot of times you're having to pay the surgery center fee. So it's going to be a $3,000 to $5,000 procedure if you have a high deductible plan. And if you look at the studies, the shockwave or the TenJet or tenotomy devices have been shown to be 95 to 96% successful at 3 years, and 97% of patients say that they would do it again. So it has been shown to be incredibly effective. It is covered by insurance. However, you will have to pay a surgery fee. So we're going to go to our second question. You have a 50-year-old female. She presents with a 6-month history of progressive shoulder pain and stiffness. She reports difficulty with overhead activity, external rotation. Physical exam reveals limitation in both active and passive range of motion. Images show no evidence of glenohumeral osteoarthritis or rotator cuff tearing on MRI. After failing conservative management with NSAIDs and physical therapy, which of the following treatment options is most appropriate? A, corticosteroid injection and continued physical therapy. B, arthroscopic capsule release and manipulation under anesthesia. C, capsular distension with saline and corticosteroid injection, or a total shoulder. All right. So this is one of the cases where steroid is actually successful. So what we're talking about here is adhesive capsulitis or frozen shoulder. This is an inflammatory process which causes a contracture of the joint capsule. And that typically you see this more commonly in females. You typically see this more in the 40s and 60s. It is way more common in Caucasians, and it is in the non-dominant hand. You have primary risk factors for frozen shoulder adhesive capsulitis, and you have secondary. Primary would be disease processes. These are your diabetes, your thyroid disease, your dyslipidemia, your Parkinson's, ALS, anything that can produce inflammation in the body that can increase that inflammation in the shoulder. Secondary is there's some type of trauma. So you either have a fracture, you could have a rotator cuff tear, breast surgery or augmentation, or you've had a stroke. The way I describe the secondary causes to the patient is it hurts to move. You've had a fracture, you've had a rotator cuff tear, and basically that contraction of the capsule is the body's way of protecting itself. It's saying it doesn't want to be in pain. There are 3 phases of frozen shoulder. You have your freezing phase, which is painful. That's typically over the first 0 to 3 months. You have your frozen phase, which is painful, and that's when you'll start to see that lack of range of motion. That can last up to 9 months. And then you have your thawing phase where you start getting range of motion back. Luckily, it's no longer painful for the patient, but that can last up to 18 to 24 months before they're completely cleared. So typically when someone comes in with frozen shoulder, it's insidious pain, and it doesn't present itself with lack of range of motion right away. A lot of times what they'll do is you'll think that this is impingement. You'll think this is rotator cuff disease. And a lot of times what I'll do is I'll think the exact same thing. And then I'll send them to physical therapy, and the physical therapist will give me a call and say, hey, they're starting to lose their range of motion. Hey, they're starting to have problems. And that's when the alarm goes off, maybe this is frozen shoulder instead. So in your physical exam early, you're just going to see those impingement tests be positive. You're going to have either a positive Neers or a positive Hawkins, and then once you start moving into that frozen phase, you're going to see that lack of range of motion. Typically, the first range of motion that you're going to see on the patient to leave is external rotation, and that's always the last one that they'll get back. They can lose up to 100 degrees of forward flexion, up to 10 degrees of external rotation, and most of them will have a very hard time getting to L5 on the back. X-rays, they're going to be normal. If they were not normal, I would have to think more of, is this glenohumeral osteoarthritis or is this AC arthritis that could be causing this lack of range of motion? Ultrasound, they're going to have a thickening of what's called the coracohumeral ligament, and you're going to see increased color flow, and you may see fluid around the biceps tendon sheath. On MR arthrogram, you're going to see capsular distension, and you're also going to see that coracohumeral ligament thickened. Treatments, we do physical therapy for this. We do steroid injections. We do what's called hydrodilatation. Hydrodilatation is where you inject anywhere between 20 and 30 cc's of normal saline into the capsule, basically trying to re-expand that capsule to increase that range of motion. Most of the time when I do hydrodilatation or I do a steroid injection, I do follow it with Spencer technique, osteopathic manipulation, to try to get that range of motion and maintain that range of motion. Once they move past my field of specialty, that's when they go to a manipulation under anesthesia, or they may have a full capsule release. So what does the evidence say? The evidence says that immobilization, like I said earlier, should always be avoided. Physical therapy is better than nothing. If you're going to do anything, steroid is better than physical therapy alone, but physical therapy plus steroid injection is better than either alone. And then a lot of times with hydrodilatation, HD, that's when it typically helps the physical therapy. So a lot of times I'll talk to my physical therapist, I'll do a hydrodilatation on a Monday, and I'll have them start physical therapy on Wednesday to maintain that range of motion. So question number 3, we're looking at a 35-year-old male presents to the emergency department after twisting his ankle while playing soccer. Radiographs reveal a fracture to the distal fibula at the level of the syndesmosis. The initial non-weight-bearing radiographs show no significant widening of the medial clear space. Which of the following additional imaging technique is most appropriate to assess the stability of the ankle joint itself? Repeat non-weight-bearing x-rays. B, MRI of the ankle. C, CT scan of the ankle. D, what are called stress views of the ankle. All right, so we're going to talk about stress views. So what we're talking about is lateral ankle sprains due to a twisting mechanism. We're not talking about lateral ankle sprain or lateral malleolar fractures secondary to direct trauma. So we're not talking about someone who got kicked in the lateral ankle or someone had something fall on their lateral ankle. These are all twisting mechanisms. So there's going to be a twisting mechanism. There's going to be the inability for the patient to bear weight. You're going to see swelling. You're going to see ecchymosis. And they're going to have decreased range of motion. And you can see that you have this twisting mechanism, and it causes a spiral fracture here. If you have someone who has a direct trauma, that's going to cause a transverse fracture all the way across. Those are much easier to treat than these are. These are classified into 3 different categories. They're called by the Weber classification. And it's Weber A means that it is below the level of the syndesmosis. Weber B is it's at the level of the syndesmosis. And C, it's above the level of the syndesmosis. So Weber A, Weber B, and Weber C. Don't ever forget your Ottawa ankle criteria. Ottawa ankle criteria is the inability of the patient to bear weight, and you're looking at least 4 steps when you're talking about bear weight. You're looking at pain on the distal tip of the lateral malleolus as well as the distal tip of the medial malleolus. And then you have your Ottawa foot criteria, which is you have the inability to bear 4 steps, but you also have pain over the navicular or pain over the base of the fifth. You want to get an AP, you want to get a lateral, and you want to get a Mortise. And what you're looking for in what's called the Mortise view is you're looking at this clear space right here. You want that clear space to be symmetric all the way across. You don't want it to be shifted to one side or the other. Another thing that you're looking for is to make sure that this fibula is overlapping that tibia ever so slightly. If you don't see any crossover of that tib fib, then that's always abnormal. One way that you can do the stress views or that mortise view is just let gravity do that with a little bit of inversion like this picture here. So this would be a widening of that clear space. You can see that they have over 4 millimeters over here, and they have no joint, or they have no space on the medial aspect, the lateral aspect, and then they have no crossover of that tib fib right there. So treatment is for non-operative, it's non-weight bearing. You're going to be in a cam walker or a cast for about 6 weeks. And then they're always going to need physical therapy. Anytime you immobilize a joint for 6 weeks, there's going to be muscle atrophy. There's going to be problems with issues with walking, strength, those types of things. Operative, they can either do it open or they can do it arthroscopically assisted. The mnemonic that I would use is the Weber ABCs. A is treat like an avulsion. It's a really bad sprain. It's going to do well. A lot of times they don't even need the boot for the full 6 weeks. B is borderline. You may be send, you may be not send. That's when you're going to get that stress view to see whether you need to send to orthopedics or not. And C, you always send. C or always send. So one thing that you can think of when thinking of ankle sprains is think of the circle of the ankle. So what makes up that circle is the lateral malleolus, the medial malleolus, and the talus, as well as any type of instability. So if you have a single break in the circle, that's non-operative. If you have a double break of the circle, that is always operative. So if you have a lateral malleolar sprain and a medial malleolar sprain, those need to go to see orthopedics. If you have a lateral malleolar sprain and there's instability, those need to go see orthopedic. So a single break is okay to treat as a sprain. A double break, it is not. And then the last topic we're going to talk about is question 5. A 24-year-old former collegiate soccer player presents with an 8-month history of deep anterior hip pain. Worse with prolonged sitting and pivoting. She reports catching and stiffness, but denies any instability. Physical exam reveals a positive flexion, adduction, internal rotation test, and you have limited range of motion at 90 degrees of hip flexion. MRI reveals something called a CAM-type femoral acetabular impingement with an alpha angle of 72 degrees, and she has a labral tear. She has completed 12 weeks of physical therapy with limited improvement. Which of the following is the next appropriate step? A, continue conservative treatment with activity modifications with nonsteroidal anti-inflammatories. B, perform intra-articular corticosteroid injections to confirm diagnosis. C, schedule for a hip arthroscopy for CAM resection and labral repair, or D, a total hip. All right. So we're going to talk why C is the most appropriate for this patient. An overview first of hip pathology. I break the hip down into the 3 compartments of the hip. You have the anterior compartment of the hip, you have the lateral compartment of the hip, and then you have the posterior compartment. Anterior compartment, I'm thinking of the joint itself. I'm thinking of your sports hernias or your adductor issues. You're looking for inflammation of the pubic symphysis, also called osteitis pubis. I'm looking for hip flexor pathologies, can see some pelvic floor dysfunction and gynecologic issues as well. Posteriorly, I'm also thinking of the hip joint itself. A lot of times, hip joint itself can go to the posterior aspect of the hip. I'm thinking of the hamstrings. I'm thinking of piriformis. I'm thinking of that gluteal musculature, especially glute med, and then SI. SI, a lot of times, will either be posterior hip pain or it can refer to the lateral hip as well. For that lateral hip, I'm also thinking of that greater trochanter or that glute med as well, and like I said, the sacroiliac joint. However, if you do the exam and there's no pain to palpation, you can't reproduce that pain, don't ever forget the lumbar spine. It is very common for lumbar radiculopathy or nerve impingement at the lumbar level to cause hip pain, anterior hip pain, posterior hip pain. So if you're doing your physical exam and you can't reproduce that pain that the patient experiences, then maybe you need to take a step back and look at the joint above. So femoral acetabular impingement is an abnormal contour or contact between the femoral head and neck and the acetabular rim. There's several different types that I'm going to show you. One is the actual problem is with the femoral head and neck junction themselves. That's a cam deformity. You can have what's called a pincer deformity where there's too much bony growth from the acetabulum, and then you can either have to make up for it with lumbar range of motion or knee range of motion. So patients who do have femoral acetabular impingement, they're much more common to have back problems, and they're much more common to tear their ACL. So if you look at a study out of the NFL back in 2012, patients or athletes who had femoral acetabular impingement were 4 or 5 times more likely to tear their ACL than athletes who did not have femoral acetabular impingement. We also care because of the rate of progression. We have a bony problem, and if they continue to impinge and they continue to cause that inflammation, the studies do show that there is going to be a rate of progression of that osteoarthritis. So this was a 10-year study that looked at rates of osteoarthritis progression, and it was 26% in the non-operative or in the operative group, and 35% in the non-operative group, which was statistically significant. The part that was not statistically significant is that it did not show an increased rate of total hips. So we're not seeing an increased rate of total hip, we're just seeing an increased rate of arthritis progression. So when should you think femoral acetabular impingement? You should think of a patient who comes in and either they were an athlete or they are an athlete, they're young, they were active, those types of things. They're going to have a nonspecific groin pain. They're going to point to either the front or the back, and they're going to notice poor hip flexibility. They're typically going to have what's called a C sign, which I'll show you in a second. And if it progresses, they're going to have mechanical symptoms. So you're actually going to see signs and symptoms of the two bones touching one another. They're going to have popping, locking, clicking, those types of things. It can continue to progress to cause a labral tear where that mechanical symptoms will actually get worse. So a C sign is when a patient is pointing to the front aspect of their hip as well as the posterior aspect of the hip. When you see a C sign, that's when you should think, is this femoral acetabular osteoarthritis, if they're old enough, or their x-rays confirm it, or is this a femoral acetabular impingement? So things that I'm looking for in a patient who I'm thinking of femoral acetabular impingement, I'm looking at their gait. Do they have an antalgic gait? Do they try to stay away from that hip in the swing and the gait cycle as much as possible? I'm looking at their alignment. Are they shifted one way or the other? Or do they have a hyperlordosis like we talked about earlier? And then I'm doing palpation. Do they have pain over the greater trochanteric region? Do they have pain over the flexors, the adductors, the ASIS, the hamstrings, the glutes? Sometimes they will have pain in the hernia region, either an inguinal hernia or a sportsman's hernia. Then the hallmark is going to be lack of range of motion. They have a bony stop at this, so they're not going to be able to get past 90 degrees of flexion or try to do internal rotation. There's 2 types of special tests that you can do, what's called the flexion adduction internal rotation test, where you take them into 90 degrees of flexion, you adduct the hip, and then you internally rotate the hip. What they're going to feel is pain. They're going to feel pain when you do this, pain in the groin that reproduces their exam. You can also do what's called Patrick test, or flexion abduction external rotation test. This is where you're going to flex, abduct, and then externally rotate. And if they're pointing of pain in the anterior aspect, I'm thinking more of hip pathology. If they're pointing more towards pain on the lateral aspect, I'm thinking more of that greater trochanteric pain syndrome. If they point more posterior, that could be either hip or that could be sacroiliac. X-rays, you're going to get an AP, you're going to lateral, and what's called a frog leg lateral. And then what we're looking for is what's called the alpha angle. So this is the line going through the femoral neck into the head. And this white part right here is a drawing of what a cam deformity would look like. So normal would be where the head and neck, or the ball changes shapes and goes into the head and neck. So it would be roughly right here, which is less than 45 degrees. Abnormal would be where it comes up here, and that's almost 90 degrees. So if you have an excess bony growth right here, that change in the ball shape is much higher, and that's why the angle is more. A pincer deformity is going to be extra bony growth coming from the acetabular rim up here. MRI is typically the next step once we confirm these on X-ray, and the MRI is really going to depend on where you're practicing. There are two common types of MRIs. There's what's called a 3 Tesla MRI and a 1.5 Tesla MRI. They're basically, the larger the Tesla MRI, the bigger the magnet. So the better field of view you can see, the smaller slices you can do, and it's much better quality. If you do not have access to a 3 Tesla MRI, then what you do need to do is what's called an arthrogram. And that arthrogram is where your radiologist injects a dye into the hip prior to the MRI, and it allows us to get a better visualization of the hip with a 1.5 Tesla. If you look at the 3 Tesla and the MRI with arthrogram of the 1.5, the 3 Tesla is better. It is the superior study. However, if you do the arthrogram, it is still very sensitive to rule out. And then the next step, so we got our X-ray. We saw they either had a increased alpha angle. We saw that they maybe had a pincer. And then the next step that I would perform would be a diagnostic injection. And what I'm wanting to do with that diagnostic injection is to confirm, does this injection take away their pain or does it not take away their pain? Because if I were to do an injection and they say, no, I went afterwards and I didn't have any relief of symptoms, then I have to take a step back and say, okay, could the pain be coming from somewhere else? Is it coming from the sacroiliac joint? Is it coming from that greater trochanteric region? When I do these injections, I do only anesthetics, so I'm only using ropivacaine because of that toxicity I talked about of steroid. Also, if you do a steroid injection for this, it will delay surgery by at least 3 months because it does, same thing with a knee or any type of joint, because it delays healing of the joint surgery itself. So you can see, you can come in under ultrasound guidance. You're going into that femoral head and neck junction right here, and I do them under ultrasound, so you can do it just like that. Now, when I do these, a lot of times what I'll tell the patient to do is I actually want them to go do what aggravates this for the next hour or 2 hours. So I want them to actually push themselves, and then I'll have them call me the next day and say, hey, I had 80% improvement, I had 90% improvement, or I had 0% improvement. And that lets me know, is the pain coming from this or is the pain not coming from this? Physical therapy does have a place with femoral acetabular impingement. What you're trying to do is just address the imbalances. You're trying to get as much internal rotation as they can get, and you're also wanting to help with soft tissue mobilization. So a lot of times they'll do some soft tissue work, whether it's cupping, whether it's needling into the adductors, the tensor fascia lata, those structures. The studies really point to surgery being the superior outcome in regards to femoral acetabular impingement. The satisfaction rate from conservative care, meaning non-surgery, is in the 44%, while the surgery is about 56%. So this is what they're doing with the surgery. They are trying to remove the cam deformity here and turn it into a normal femoral head and neck junction like that. And if there is a pincer deformity coming off that rim, they'll also remove that bone as well. With surgery, they do have a high probability of good to excellent results. They do have effective joint preserving that does not increase the risk of a total hip. And most of the studies point to the surgery being good for about 10 years. And then eventually it does continue to progress to osteoarthritis. This is a difficult surgery due to the vascular nature of the femoral head and neck, and it can increase the risk of avascular necrosis. So this is something that you want to find a true hip specialist before you refer to. So takeaways from today, we talked about tendinopathies, we talked about eccentric loading, that's the magic word, and then we talked about imaging for tendinopathies, we talked about frozen shoulder, we talked about pain, stiffness, and then recovery. Physical therapy and corticosteroids are very effective, and then we talked about which Weber classifications descend. We can treat Weber A like an inversion ankle sprain. We can maybe treat Weber B, depends on those stress views, and we always send Weber C. And then FAI in your athletic population, the surgery does slow the progression of osteoarthritis. It does improve lumbar lordosis, and it does decrease the risk of ACL tear. All right. So those are my references.
Are there any questions for Dr. Ham?
Yes.
Good morning.
Morning.
I've seen competitive athletes as young as 6 years old in the outpatient clinic, and they'll come in saying that coach needs a note saying either they can play on this injury or they can't. And typically I say, okay, even if it's an acute tendon injury, they probably shouldn't be doing tumbling or gymnastics or whatever it is they're doing. So how would you counsel a patient or recommend counseling that patient and parent if you don't want them to rest completely, but you also don't want them to go back to practice? Or would you refer to sports medicine immediately or PT?
So I would want to know how much they are practicing and playing. With pediatric patients, you want them to practice and play less hours per week than they're alive, meaning years of age. So, a 6-year-old, you want her doing gymnastics less than 6 hours a week. If you talk to some of these gymnastics, some of these swimmers, you talk to some of these baseball players, they're doing much, much, much more than that. So a lot of times it's talking about, hey, maybe let's back off to maybe your age-appropriate guidelines. Let's make sure you're getting good quality sleep that will help with recovery. Let's make sure that you're having a good, solid diet. And then maybe we can talk about, ramping you back up after that. But a lot of times it's making sure that you're getting good quality rest so that they can continue to compete. So if they would have come into me, I would say, all right, how many times a week are you practicing? How many times a week are you playing? What kind of things are you doing at practice, and what things hurt the most? Maybe we can have you do things at practice that just doesn't hurt while we recover, and as long as your pain stays less than a 2 or a 3 out of 10, I'm okay with it. Now, if they come in and it's a baseball player and they're playing for, 3 different teams, a travel ball team, the school, and they're pitching way more innings per week than they're supposed to, then we're talking about shutting them down completely. So a lot of times it's about meeting the parents and the athletes and just setting expectations.
Thank you.
Yeah.
When you were talking about ultrasound versus MRI, do you feel like we have, I don't feel like I'm seeing a shift to ultrasound yet, that it's still MRI. So even with it being operator dependent, it still seems like from your numbers that ultrasound would be superior. So why are we not seeing a shift yet?
Orthopedic surgeons. They still trust the MRI more than the ultrasound. They agree with the literature, but they're not quite ready to trust the ultrasound completely. A lot of times I will do a diagnostic ultrasound to try to save patients money, and it will show, full thickness rotator cuff tear, and they'll still get an MRI. Now, some of that is for reasons so that they can, they're planning the surgery, not me, so they need to know certain things, and that's very important. But a lot of studies do show that diagnostic ultrasound is superior if done by the right operator. And maybe they just don't trust each operator yet. So, and part of that, is medicine and the fact that there is not a good criteria yet established to say who is a good operator of an ultrasound and who is not. There's not, a board test that you typically take. There's not so many hours per week that you take. That's the part that's still in development in regards to sports ultrasound.
Any other questions? All right, thank you, Dr. Ham.
Thank you, guys.
We'll start back at 8.
Dr. Emily McGovern is a rural medical oncologist at Lakewood Health System in Staples, Minnesota. She completed her medical school training at LMU-DCOM in 2018. She then went on to complete an internal medicine residency at Abbott Northwestern Hospital in Minneapolis, Minnesota, followed by a fellowship in hematology oncology at Gunderson Health System in La Crosse, Wisconsin. Dr. McGovern is the co-founder of a nonprofit, the Rural Cancer Institute, whose primary mission is to improve healthcare equity through research, education, and advocacy. Please help me welcome Dr. McGovern.
Hello, everyone. Thank you for having me. Kind of exciting for me today because I'm talking about things that happen before patients see me. So I'm excited to talk about updates in lung cancer screening, although I will give a mention that there actually aren't a lot of updates in the screening world, but there are updates in how we're treating things and catching things earlier. I have no disclosures today. Our objectives today are to really understand the importance of early detection in lung cancer. Obviously, we know catching cancers early is great, but how important is it? I also want to review our previous USPSTF lung cancer screening recommendations and the most recent updates, which are from 2021. I want to review the current lung cancer screening rates and ways that we can possibly improve those rates, and then discuss new therapy options for early stage and metastatic lung cancer and the importance of biomarker testing. So epidemiology, I think it's always nice to set the stage with just how much lung cancer are we seeing now. And we still know that lung cancer is the leading cause of cancer deaths in the United States. That really hasn't changed for the last several decades. And we know that there are expected to be a tremendous amount of patients who will be diagnosed with lung cancer and die from lung cancer in this year, and likely will increase in the years to come, unfortunately. So on average, we're expecting about 226,000 new cases of lung cancer, more so in women than men, which has switched recently in the last few years. And we're expecting about 124,000 deaths from lung cancer. Those are more in men than women. Each year, more people are dying of lung cancer than breast, colon, and prostate cancers combined, which I think is just a huge number and crazy way to think of it, because we know those cancers are so common. And then the leading cause of lung cancer in the United States remains tobacco use. So, I think there's been lots of conversation about what other things in our environment are potentially raising that risk for lung cancer. And, we know radon, some other toxins that we're not even aware of more likely are causing lung cancer, but tobacco is still by far and away the most common cause. This is a picture from the state of lung cancer in 2024 done by the CDC, and it really shows rates of lung cancer by state. The darker blue are higher rates of lung cancer. The lighter blue are the lowest rates of lung cancer. And I think this is just a way to kind of show us, West Virginia, Kentucky still remain those highest rates of lung cancer in the United States, so very close to home here. And then you can see that there are parts of the eastern United States that have a little bit higher rates too, with more of the Utah, New Mexico, Southwest regions being the lowest rates. I liked this data, so this also came from the state of lung cancer in 2024. This is really showing the importance of early diagnosis. So the top bar is showing stage at diagnosis. So as an oncologist, stage is a lot. Stage is how I determine a lot of the treatment recommendations I'm giving for patients. Stage of diagnosis, unfortunately, is mostly stage 4, which you can see from this purple area at 43%. We really would love to see that 43% be in the blue zone. The blue zone is our stage 1 diagnoses, which of course means that we can potentially cure patients. The 5-year overall survival is also tremendously based upon that stage. You can see that early detection really leads to a much higher percentage of 5-year survival. 64% of stage 1 diagnoses for lung cancer survive at 5 years. Versus you can see that purple zone where it's metastatic again is only 9% overall survival at 5 years, which sounds really low. However, that is a drastic improvement from what we were seeing even just 10 years ago. So previously, really before about 2012, if you were diagnosed with stage 4 lung cancer, your overall survival or life expectancy was really somewhere around 6 months or less. Now, that's a whole different story. I'm able to tell stage 4 lung cancer patients their overall survival is sometimes greater than 2 years. And some people surprise us even more than that. So again, really important that we're getting it at stage 1, but things have changed in the stage 4 realm too. So, importance of lung cancer screening, this is really multifactorial. So, our screening with annual low-dose CT scans can reduce lung cancer death rates by about 20% by detecting lung cancer at that early stage, or stage 1. Even stage 2 or 3 would be better than the stage 4. Assuming perfect adherence to the screening recommendations, the life years gained for patients is expected to be estimated at 15.5 to 21.3 million years if we were able to save all of these patients and detect things at an earlier stage. And when you think about that in healthcare costs, getting these people diagnosed earlier on may save our complete healthcare system the trillions of dollars, which is crazy to think of, but also when we have higher diagnosis, or a higher stage at diagnosis, we are having to put patients through surgeries, sometimes extended hospital stays, immunotherapy, chemotherapy, radiation, imaging, and that really, really piles up in terms of healthcare burdens. So I think looking at this timeline is also super important. So we really started thinking about lung cancer screening starting in about the year 2000. We said, gosh, we need to fix these numbers. These numbers are far too high for mortality rates. By 2002, the National Lung Screening Trial had come about. This was really the first published data on lung cancer screening, also known as NLST. And this is really where we came up with the first USPSTF recommendations. That was initially started in the year 2000. It closed after 5 years and really said that there was some mixed data on whether or not patients were actually seeing overall survival improvements or whether or not we were harming them by doing low-dose CT scans. By 2013, that is when the first USPSTF recommendations came out that we should proceed with the low-dose CT scan for lung cancer screening. And the recommendations that they gave were pretty simple, and you may be familiar with these. So this was at the age of 55 to 80, they were eligible to undergo the low-dose CT scan, and they had to have a history of at least 30 or more pack years of smoking, and had to be either a current smoker or quit within the last 15 years. So this was a big movement, and obviously it made news. We all were hearing about it and how we needed to proceed with thinking about ordering these. However, there was not really conclusive data on if this was actually going to help our patients, and the AAFP really recognized that early on, and they recommended it as a Category B recommendation, but with a lot of hemming and hawing and saying, I don't think we should be doing this. And so that is part of the reason why we haven't seen the numbers pick up and why we may not be as familiar with things with this. So cancer screening rates. I like looking at this because this is actually the percentage of eligible population for each of our known screening for cancer guidelines. So you can see there's a large amount of our population that meets criteria to undergo cervical cancer screening. Obviously, we start at a young age, we go through age 65, and we have all women eligible. Breast cancer screening, relatively the same. We can see that we're starting to screen patients at an earlier age, especially those if they're high risk. And so the amount eligible for breast cancer screening is also incredibly high. When we look at colorectal, same story. Lung cancer screening, very dismal, because we knew there was only a small amount of our population that would be eligible for this. So when we think about the hype of getting these screenings, that's a big part of why we don't hear as much about the lung cancer screening recommendations. So when the AAFP kind of said, the NLST just doesn't give us enough data to move forward with this, there was another trial that was actively being done called the Nelson trial. This was a large Dutch-Belgian lung cancer screening trial, also started in the year 2000. It was a randomized control trial, so it was done in all the right ways. Their goal was to show a reduction in lung cancer mortality of 25% or more using the low-dose CT scan. However, there was a caveat that they were only using high-risk male population, and they wanted 10 years of follow-up, which was more than the 5 that NLST was using. So the median age of this population was about 58 years old, and they had a median smoking history of about 38 pack years. And 44.9% of them were former smokers. So of course that other group then were current smokers. Obviously this was not the perfect study for us to base our recommendations off of. Again, it was only males, they were high risk, they were predominantly Caucasian because it was a Dutch-Belgian study, and so it wasn't really reflective of our population. But it still had tremendous data that came out showing there was an overall survival benefit and there was a low number needed to treat in order to move forward with this. So eventually, they ended up doing a subgroup analysis that included women and 10 years follow-up, and it turned out for that high-risk women population, the benefits remained the same. So they also found that screening-detected lung cancers were substantially diagnosed at stage 1A or 1B in that screening group compared to the control group. So essentially what this is saying is that by undergoing the screening CT scans, they were diagnosing it earlier. For those that weren't getting diagnosed with lung cancer on that screening CT scan, they were not being found as early, which makes sense. They were still being diagnosed with it, but usually a symptom had to occur or some other imaging was done for a follow-up or a symptom that then led to the diagnosis. So that was the goal, was we wanted to see stage 1A or 1B at time of diagnosis so that we could prevent any kind of long-term issues and hopefully cure them of the disease. They also saw an incredibly high adherence rate, which I think is wonderful. So in the male-only group, they had an adherence rate of about 87.6%. In the subgroup analysis, with the high-risk women added to it, the adherence rate was 90%. And that goal was that they have at least 3 low-dose CT scans done in a period of 10 years. So after they reviewed that data, really essentially what they decided was we should re-update our guidelines. We know that this is offering benefit to patients, but maybe we should tweak some things. So in 2021, USPSTF offered their most updated guidelines. Again, this is our most recent update published from them. And really what they did was lower that age where we start screening to 50 years old from 55. And they also lowered the pack year history from 30 years down to 20 years. And then it remained the same where you had to have quit smoking within the last 15 years or be a current smoker in order to qualify for the low-dose CT. So I think this was a tremendous improvement because obviously this widened our population that we were screening and allows us to have earlier detection. And it's very similar to what we've done with mammograms and colonoscopies here in the last few years. So lung cancer screening rates, they still remain dismal. And I think a lot of this has been because of kind of the uncertainty of whether or not these are truly beneficial for our patients. And I think it's just not as much on the forefront of our minds as mammograms, colonoscopies, cervical cancer screening. So in 2022, only 16% of high-risk lung cancer patients in the United States were receiving low-dose CT scans for lung cancer screening. That's horribly low. And I think, when I looked at the other data on how many of our patients are getting mammograms, how many are getting colonoscopies, really that number that are getting those are somewhere between 65 and 70% compared to the 16% for lung cancer screening. So there's a huge gap there that we really need to fill. And really that all starts with you all and in all of our clinic visits, just making sure that we're checking on the history, making sure we're talking about the benefits of these CT scans. So I think it's also important to think about why are we seeing that low number? And there are a lot of reasons. Obviously one is, again, starting probably with us as physicians, are we recommending this? And again, there's some discrepancies on whether or not people feel strongly about it or not. But beyond that, if you're mentioning it to your patients, some people say no thanks. And I think, as a rural provider, I know there are definitely a lot of restraints for my patients when they are thinking about having screening mechanisms done. So cultural barriers for sure can come up. I think some people are scared if you get a low-dose CT scan, they're going to have to quit smoking, or someone's going to tell them to quit smoking, and they don't want to. So that can for sure be a barrier. Financial barriers, obviously. Most insurances, Medicare included, are covering this now, but I think we have a tremendous population who are uninsured, and for them, this is just not feasible. I think location barriers, again, rural, when you're telling people, hey, I just saw you for your annual wellness exam, now you have to come back in a week and have a CT scan, you're gonna have to take off work, you're gonna have to be here for an hour. Those are just unappealing things for people. And then fatalistic beliefs, again, I think it's, I'm gonna have this screening scan, we're gonna see that I have lung cancer, why would I bother? I don't want to do anything anyway. And so these are all things to just make sure that you're trying to, overcome those barriers when you're having conversations about this with your patients. So the facts, I think, this is to help kind of load that conversation for you when you speak with your patients. And there are a lot of pros, which we've already talked a bit about. Early detection is obviously the most important thing. We know that for all cancers across the board. It helps improve our overall mortality rates. It improves the costs of healthcare burden on patients and for the world. A pro to me is also incidental findings. So I can't tell you how many patients I've met who have had a low-dose CT scan and they found a lymph node enlarged in their axilla. We get a biopsy, they have lymphoma. So there can be benefits to finding those incidentalomas as well as cons, which we'll talk about as well. But they're certainly helpful. And then again, the cost of overall for healthcare. I think the cost in my mind is the very bottom of my list, but it certainly is still a huge topic when we're talking about healthcare in general. CT scan radiation-wise emits compared to a regular CT scan is about 1/5 the total dose of radiation. And so when I think of that, I order CT scans for patients at least every 3 months a lot of times. So I'm certainly giving them a lot more radiation than what they are with this small negligible amount with a low-dose CT scan. Obviously, we're going to see increased biopsy rates. Biopsies are not, foolproof. We certainly have complications that arise with lung biopsies in particular, whether that's pneumothorax requiring chest tube placement, or hematomas, infection. There's all sorts of things that can happen, and so that is definitely something to be considering. We also find false positives, which we'll talk a bit about. That's inevitable with any of our scans. We see that with mammograms. We see that with colonoscopies as well. Patient anxiety, I always say scanxiety is a real thing. I see it every day, where people just have a lot of anxiety about having pictures done and what we're going to find. And so knowing that they're going to need one of these CT scans done once a year can certainly be discouraging and sometimes anxiety provoking for them. Incidental findings, so again, we're finding things that maybe we don't want to find or things that really don't mean anything for the patient clinically, and that's just what we run the risk of by obtaining imaging more frequently. And then higher cost. This is just a way to look at, if we go through with 1,000 subjects, the black areas, those little black stars, are all screens negative. So the majority of your patients that undergo low-dose CT scans, they will be negative, which is great. The red area the larger red area are false positives that didn't require biopsies. So when they don't require biopsies, usually what ends up happening is a PET scan is performed if there's a nodule that looks concerning for malignancy. If that PET scan comes back negative, they don't need to undergo a biopsy. There's no intervention required. And then the kind of halfway red star point are false positives that did require a biopsy. And those are the ones we really want to try to avoid at some point. And AI very well could help us with that, which I know is kind of another weird topic to discuss in medicine, but it certainly is helpful in this realm. Unfortunately, the screening detected cancers is really only those 3 stars, so 3 out of 1,000 people. But if you're one of those 3, it's a really big deal. So positive findings, now this is more kind of the field of what I do every day, but if you have a nodule or a mass that shows up on that CT scan, I would tell you first and foremost, my 2 recommendations that I give to primary care providers or pulmonologists if they run things by me is start with either a PET scan or a biopsy. Now obviously biopsies, depending on the location, can be really difficult, so it's nice to start with a PET scan in a lot of those cases, because if that nodule or mass is greater than 6 millimeters, it should be FDG avid on a PET scan, and it can give us a hint of whether or not this is truly malignancy. It could also give us a mixed signal where if there's any uptake, it could be infectious, it could be inflammation. But I would say our radiologists have gotten very good about being able to determine, based off of how much SUV uptake we see, what could be malignancy or not. And it makes it a lot easier for planning a biopsy if that's needed. So now looking at a bit of our advancements. So there have been a lot of changes, like I said, in oncology world. Really in the last 15 years are when things started, and they've only picked up every year since. So in terms of early stage lung cancer, so if we're truly catching these at stage 1A or 1B diagnoses, which is the goal, we now have minimally invasive surgeries which can be done robotically. So the long recoveries that we used to see with lobectomies or wedge resections, they still can be present, but really people are recovering a lot better than they used to from these surgeries. I would say by far and away what I end up using for early stage lung cancers nowadays is SBRT, or stereotactic radiotherapy. So a lot of the patients I see with smoking history in particular, somewhere between that 5th and 6th decade of life, they are very comorbid. They may have signs of COPD, emphysema, heart failure already, and that therefore will limit their risk or limit their ability to undergo surgery. So anytime they have reduced diffusion capacity or reduced FEV1, we're really stuck with saying you are not a candidate for surgery, and that's really actually a good thing in my mind now because SBRT is just so good. So this is a radiation therapy that is a high dose and very localized to a mass or a nodule, and it's usually done within 3 or 5 daily treatments. So instead of going through a big surgery, being in the hospital for a week, they go to a radiation center. They spend probably a total of about an hour there for their treatment, do that 3 times, and the cancer goes away. They're usually left with a scar there, but it is very, very effective. And the more data that we have on surgery compared to radiation now are essentially showing they're very close to equivalent. The original trials that were done looking at that really didn't put into impact the comorbidities and why people weren't having surgery. And so really it's really looking up for us on being able to do SBRT for these now successfully. We also have this little thing called ctDNA, which has not really come out with guidelines yet, but it's a way for us to detect using genetic testing for cancer cells floating within the bloodstream, whether or not these cancers have recurred after they've been treated. And that is really also improving our overall survival. And then we have 2 things that we are now doing for adjuvant therapies. So TKIs and immunotherapy. I'll talk about immunotherapy first because we use immunotherapy for 18 different cancers now, and it has really changed our world really in the last 5 to 10 years. And immunotherapy can be done after surgery, it can be done after radiation, can be done after chemo, but this has really been the game changer for improving overall survival for stage 1, 2, 3, and 4 lung cancer patients. You may have seen commercials for things like Keytruda, which is certainly one of the immunotherapies that we're using. It's a PD-L1 inhibitor, and we also use a drug called durvalumab a lot. It's been approved in all of those settings as well as kind of a maintenance therapy to help the patient's immune system keep that cancer in check. Now TKIs, so this is my last slide, I promise, but really this came about after about 2009. After we sequenced the human genome, we were able to find all sorts of mutations that were relevant for cancer growth, and this has just kind of blown up our worlds in terms of treatment options for patients. So pretty much all lung cancers now, even stage 1s, well, not stage 1s, but stage 2, 3, and 4, we are doing what's called next generation sequencing on so that we can find which mutations their cancer may harbor. If they have one of these mutations, we now have targeted tyrosine kinase inhibitors for each of these mutations that can help them avoid chemotherapy altogether and has really, really changed the overall survival for lung cancer in general. The 2 most common that we use after an early diagnosis are the EGFR mutations and ALK mutations. They're fairly rare, not super rare. As you can see on here, EGFR is about 30% of all lung cancer patients, particularly if they're not squamous cell and usually when they don't have a history of smoking. But we still do find them, and when we do, I call them our unicorns because they respond super duper well and are living for multiple years, so more than 2 years on average. So to summarize, lung cancer remains the leading cause of cancer deaths in the United States. We have a lot of work to do to improve upon that. The USPSTF lung cancer screening guidelines were last updated in 2021. I could not find that there's any hint that they may be updated soon. I think we really just need to start utilizing these general guidelines from when they came out originally. And we need to continue to focus on that larger demographic for testing. And then I think despite low-dose CT scans leading to improved detection rates and earlier diagnosis, we just are not using it. So I encourage you all to keep this at the forefront of your mind when you're talking to patients and making sure they get this screening when they need it. And then I just have my references.
We will wait on questions until after the next lecture. So thank you, Dr. McGovern.
So I want to introduce our next speaker. Dr. James Dalbo is a 2020 graduate of LMU-DCOM. He completed his neurology residency at University Hospitals Cleveland Medical Center, Case Western Reserve University, where he is currently a clinical epilepsy fellow. He has published many peer-reviewed journal articles and several books in the field of medical and neurology education. Please help me welcome Dr. Dolbo.
Hey guys. Is this the clicker? Awesome, thanks. And it's the center one? Love it, thank you. Hey guys, I'm Jim. Thanks for having me. I rarely, as a neurologist, get to talk with mainly primary care. This is such a delight. A lot of times there's this war between neurology, or the subspecialties, and primary care, but the fact is that there is no better advocate for our patients, the ones that we see in clinic, than you guys, so thank you so much. So, we'll talk about today is primary stroke prevention. That is just the guidelines that the American Heart Association, the American Stroke Association puts out every year based off of 100 years of data and how it's been able to accumulate every year. And what our recommendations are for, typically for primary care when it comes to patients that don't have a stroke yet but are at really high risk. What we're not going to do is talk about a bunch of minutia, and there will be very few statistics in here and no big, we're not going to go over the tiny little bits. These are the big concepts. I don't have any disclosures. This is what I just talked about, the objectives. There are 8 big stroke risk factors for primary care that primary care docs can address so super quickly and on basic yearly lab tests and simply in you guys' heart-to-heart conversation with patients. And we're going to talk about each one of those. So first, what's a stroke? You guys know what a stroke is. It would be useless to go over it. Effectively, there's just not blood that gets to a part of the brain, or there's too much blood in a part of a brain. Primary prevention is when it hasn't happened yet. Secondary, we'll talk about at the very end when unfortunately someone does have a stroke, but now they're terrified and their life has changed. And every little bit that they can be guided is super helpful because that fear rules their life. And it's so hard to get in to see a neurologist. You guys are 100% what they need. So these are the 8. There's 8 there, right? Yeah. So the biggest effect, I put them in biggest effect to smallest effect. We're going to start off by talking about diet and exercise. Turns out, I know that my primary care just weighs me, but doesn't look at anything about body composition or talk to me about my exercise. This is huge. Sleep is last. So diet. We'll talk about strong recommendations from American Heart Association and Stroke Association, moderate and then weak, and then no recommendation on it at all because it doesn't work. So strong, I wanted to get this one out of the way first because no one likes to talk to their patient about the Mediterranean diet. In fact, I can't even spell Mediterranean if I'm not looking at it. So, and my wife is Lebanese, so I should know this. So the fact is, so many patients try to get around the Mediterranean diet by saying, I'm just gonna have a handful of nuts, or I'm just gonna only eat this one thing that I think is Mediterranean, like I'm only gonna eat fish and then I'm gonna have my steak. So the fact is, a Mediterranean diet can significantly decrease stroke risk, but it occurs through decrease in blood pressure, and it actually gives you more energy, a Mediterranean diet. It gives you better fiber, and so you're more likely to go exercise once you change your diet, because that's a habit that you have 3 times a day. So before I do that, I haven't put in a slide here yet about what is the stroke, or the chance of stroke. What is the risk? It's different for everyone in this room. Effectively, if you don't have any stroke risk factors at all, you don't have hypertension, hyperlipidemia, everything's perfect for you, and you exercise 15 minutes a day, then you have a 1% chance in 10 years of having a stroke. So every one of these 8 that you go up 20, 50%, et cetera, you're up to 10 to a 20% risk of stroke over the next 10 years in no time. So that's why all these are super important, specifically this one. This is the habit setter. Once you get a Mediterranean diet, which I personally don't, so I would be the last one to be able to talk to them about it. But this habit sets everything else in motion. The one thing that doesn't, I guess, the one thing I have adopted here is the bottom one. If you just substitute a little bit of potassium chloride instead of your sodium chloride salt, it does significantly, most studies show that it significantly reduces stroke risk. To what degree, we're not exactly sure, but this is an easily modifiable change for your patients. So what doesn't work? This is the biggest one for me. Patients come all the time and say, we referred to you because I'm on all these supplements and my doctor doesn't know which one's best for me. Turns out supplements don't work. Studies on studies on studies show you can load up with as many vitamins as you want. It doesn't decrease your stroke risk factor. So if you have, especially here in Appalachia, if you've got people that are spending $50, $100 a month on their pills, not a recommendation. These people can easily spend that on a gym membership and decrease their stroke risk factor or stroke risk by so much more than spending money on supplements. This is, especially in our veterans, for some reason, this is a big issue. Also, there are a lot of very expensive supplements with long-chain fatty acids. There's no effect there at all. I know that there are several people pitching these things online and on TV, and it's $100 a month membership or subscription. Doesn't help. So a summary, Mediterranean diet significantly helps. Substituting a little bit of salt is the perfect middle ground. What type of salt you use is what I do. All the other much more expensive stuff doesn't. So activity level. Strong recommendation from the American Stroke Association is that you get some exercise. That seems pretty obvious, but what patients don't, what they're scared of is, oh my God, I have to buy a treadmill and I have to run for half an hour a day as much as I can, and my knees are bad and my head hurt. No, it's so much simpler than that. Just go on a half-hour walk with someone you love. That's it. Or do a 15-minute jog, and that doesn't mean every day. It just means on the weekdays. I go on a 30-minute walk regardless, and it lowers my blood pressure anyway. So, and it doesn't have to be outside. Walk around work. That's what I do if I ever have time. If someone doesn't come to an appointment, I do my walk. But this is also, just like diet, this is multifactorial. It improves all the other risk factors as well. This is one that I put a lot on because I noticed that my PCP doesn't do for me, and I think would be really great. BMI is such an enormous risk factor. It's a manageable risk factor, and I was able to pull this out of the data, that there's an increase in 10% for each 5 units of BMI. That's enormous. So if you have somebody that, you have so many people that will say, well, my blood pressure is, let's say they're obese, but their blood pressure is beautiful, and they have no hyperlipidemia, and they do exercise. On its own, BMI is still an enormous risk factor. And it's not sizist to still talk to them about this. Also, down there at the bottom, you'll see waist circumference alone. So it's not necessarily just BMI. Waist circumference alone has just as impact. So, blood sugar. I'm going to be the last one. I don't take blood sugars in my office, in my clinic, but I always follow up on what the primary care did. The internal medicine notes are my best friend. The family med notes are, I read every single one of them. And so here what we do in neurology is we don't care about anything less than 7. A lot of people say, you got to get down to 6.5. The data's not there for 6.5. So getting someone below 6.5 is really, really difficult for people with diabetes, but it's a little more lenient, and the distance between 6.5 and 7 can be hard for patients, but it is not statistically or clinically significant for stroke reduction. So if you have patients that are resistant or just need to go on a second or third medication in order to get down there, don't worry about it. Statistics say 7's fine. Blood pressure. That's another one where there is a good amount of leniency in our data. So there is not a statistically significant difference between less than, or systolic of less than 130 and less than 120. And so if your patient is just dead set on getting down to less than 120 systolic, or a systolic of 120, then just let them know. It doesn't matter how many medicines you're on. There's no difference in the data. What the data shows is if you're less than 130, that's optimal for patients for stroke risk factor reduction. Hyperlipidemia, that number looks huge to a lot of you guys, I'm sure. 190 is big for us. But once again, the leniency of the stroke literature, we only recommend, well, for reasons why anyone should be on a statin, as everyone here knows. But statistically, treating less than, or greater than 190 LDL is the only statistical marker that we have. We've tested all of them, and I guess a higher degree of control doesn't seem to reduce the stroke risk by a statistical margin. So if you have that patient that's really struggling and all they want to do is stroke risk factor, less than 190 is where we add the statin, and then we go from there. Typically, if someone comes into the hospital, we put them on a statin no matter what if they're over 100. But long-term management, outpatient, we say less than 190. I know that's a little contradictory, but rarely are we the first ones to see them to throw people on statins anyway. What is not recommended, because there is no effect, is these omega-3 fatty acids. They can be unbelievably expensive for these patients with low income, and statistically they do not work for stroke risk factor reduction. So tobacco use. I assume, as mainly medical professionals in here, far fewer of us smoke or use tobacco than probably our average patient. That's a great thing, because we have a lower risk factor for stroke then, because tobacco use, unfortunately, is one of the highest, but it's the most stubborn that we have asked and asked patients forever and ever to not do. And no matter what we do from a medical perspective, it doesn't seem like we have been able to decrease the degree of stroke risk from our patients. It's these outside of the medical appointment things like the societal change that seems to have done that. So counseling doesn't really work, what we notice in both primary care and stroke from the guidelines that I've been able to see. So you still make those recommendations. Please don't smoke. Please don't do tobacco or use tobacco products, but probably not us that's going to change. Where we're going to be able to help is the pharmacotherapy with that. Now that has a statistically significant improvement in our patients, specifically stroke risk factor reduction. Switching to e-cigs or any sort of vape doesn't seem to help at all reduce the risk of stroke. Lastly, of the 8, people with obstructive sleep apnea. As I know all of you guys know that OSA is going to be an independent stroke risk factor for the cardiac and the pulmonary risk factors, the hypertension that it causes, a lot of these things. But since that was found, there haven't been long-term studies on if counseling affects that or helps, or if treating treating with a CPAP helps reduce stroke risk factor. We know that it helps with stroke. We know that it helps with pulmonary, but we don't know if those translate over to reduce stroke risk factors or reduce risk of stroke. So special cases is a little bit more neurology, but asymptomatic carotid stenosis, as you guys know, carotid artery, it can typically, screening is not recommended by the American Stroke Association, but if someone is symptomatic, says, you know, when I stand up and I get really lightheaded, or when my arm goes weak, when my blood pressure goes low, things like that, it's a good idea to get the vessels looked at. Stenosis is always the scary word, and a greater than 70% stenosis is where the studies really draw that line. It has to be drawn somewhere. And so typically you'll have a radiologist that knows these guidelines and will give you greater than 50%, greater than 70, greater than 90, or probably occluded. 95, then it will probably go occluded. So what the recommendations are: routine screening is not recommended, doesn't need to be done, especially on asymptomatic patients. But anyone with a greater than 70% stenosis or carotid, yes, you still need to do 1 through 8. They're definitely much more important now than they ever have been, but it's going to be seeking guidance to what we need to do about that. So this is where you need to get either the neurologist isn't going to help that much because we're not going to be the one that takes them immediately to surgery. So if you could just send them to vascular, that's always helpful. If you have a neurologist that you have a great relationship with, we're happy to see them, but if they need surgery, we're going to end up secondarily referring them to someone as well. And all we're going to do is go over those same 8 risk factors, and we will say, okay, well then we'll re-image you. And if it's starting to get worse, we're going to send you to neurosurge for an evaluation, or vascular surge. So we're a little bit of a middle person there, which might be that helpful for patients of lower income or areas of low access to healthcare. The patients with greater than 70% stenosis, treating with both vascular surgery and doing a lot of medical, so let's say antiplatelets, statins, things like that, that hasn't been teased out yet. So the main thing is to remove that occlusion, stabilizing the clot and removing the occlusion. So next, oh, that's obvious. But cerebral vascular disease, that just means that those same vessels that are in your neck, the ones that are in your head. So if they were to get, for any reason, vascular imaging of the head for that patient that gets really weak when they stand up, this vascular imaging is typically what's done. So if they say that there is cerebral vascular disease, which is just plaques in the brain that are not occlusive at that time, recommending going through the 1 through 8 again. However, adding an antiplatelet statin for just that reason is not quite panned out in the studies yet. However, it would be extremely rare to have somebody with cerebral vascular disease and nothing else that's treatable from the 1 through 8. And so if you have that exam that comes back to you from the radiologist, it's a good idea to go through each one of these 8 for the patients, because you will find something will be positive that you can help. This is one that not a lot of people think of, which I found out about in residency, and it has so come true. I've had 2 patients that I've noticed big impacts here. So patients that have migraine, with or without aura, are at increased risk of stroke. And this was, I still don't understand I don't understand the physiology of this, and I'm not sure anybody does, but, because there are 2 different pathways. But the strong recommendation is that if you have patients that have migraine specifically with aura, so a visual aura, a sensory aura, whatever, right before their migraine, avoid estrogen. So if they're on a contraceptive, make sure it's a progesterone only or a non-hormonal contraceptive, because that is going to double down on their stroke risk factors. Secondary stroke risk factors, these are the ones that, now these are my patients, the ones that I see all the time. They absolutely should be on an antiplatelet and a statin. This is, if it's ischemic, obviously. It needs to be an ischemic stroke for them to be on this. But one big thing that I want to put out there, so many patients come to me 2 years down the road and say, well, let's have them seen by a neurologist. They had a stroke a few years ago, and they're still on their, it's called DAPT, or dual antiplatelet therapy. No patient, per the guidelines, should be on dual antiplatelet therapy after a single stroke, long term. This should be only 3 weeks or 3 months down the road, they should be on dual antiplatelet therapy. So if you see that, look at the neurologist's note, and it should have stopped. Someone put in this order wrong, or it should be explicitly stated that they should be on this for some random reason. But they should be on a statin and antiplatelet, but a single antiplatelet. So in conclusion, e-cigs don't help. Diet is the most important, and all these nutritional supplements do not work at decreasing stroke risk factor. If you see a carotid stenosis over 70%, get them checked out by somebody for evaluation. Avoid estrogen and migrainers. And if you see that the patient is chronically on dual antiplatelet therapy, review it, because that's almost never the case. All right? Thank you, guys.
We'll take questions now, both for Dr. McGovern and Dr. Dolbo. I do have a question from the virtual audience for Dr. McGovern. Does a history of smoking cigars qualify for lung cancer screening? And if so, what are the thresholds to screen?
I would say yes, and I would still use the same tobacco smoking recommendations. So not pack per years, but if it under age or years of smoking, I would just go by that.
I have a question for Dr. McGovern as well. So I've had a number of patients who kind of like age out of lung cancer screening, like maybe they started screening when they were like 14 years after quitting or 13, and then after 15, CMS stops paying for it. And a lot of times those folks are kind of like anxious. I'm assuming their like risk of cancer doesn't decrease. So just wondering how you advise those patients, and if you like are looking out for certain things after that 15 years.
I wonder if that recommendation will change ever, and I really hope it does. So I'm assuming in those patients they never had any pulmonary nodules of concern over that time period. And so then, you know, if you follow them for 15 years after tobacco use cessation, that risk of developing a nodule that turns into lung cancer is relatively low. I don't know the exact numbers, but if they haven't been generating nodules over that time frame, they likely won't start that far after quitting. So I guess there's that reassurance factor. If they've had any nodules, you know, oftentimes radiology will recommend that follow-up so we can push those out farther and farther. But if they're clear, you know, I do think it's probably fair and reasonable to just stop.
I got one question for each of y'all. The first one for Dr. McGovern, are there any recommendations for like secondhand smoke exposure and cancer screening? Because I mean, smoking rates have gone down, so secondhand smoke exposure has gone down, but I think it still exists.
Yeah, unfortunately, there are no recommendations for secondhand smoke exposure. I wish there were, because I think, you know, of the main factors that increase your risk for lung cancer, it's tobacco use. Secondhand smoke is number 2. So again, I think there's ways that we need to have these guidelines progress eventually or be expanded upon, and that would be one of my thoughts that it should be.
And then question for Dr. Dolbo. we have a physician in our area who thinks of himself as a long COVID type specialist. And so we get patients that are coming into the ER with basically that are on not only single anticoagulant therapy, but triple anticoagulant therapy with aspirin, Plavix, and Eliquis or Xarelto. Basically for, I guess his thinking is, long COVID and prevention of clots and that kind of thing. He thinks it's primarily a CNS process and that kind of thing. So I didn't know if there was anything in the neurology literature that would suggest that that would be any sort of appropriate type treatment.
Gotcha. I'm sorry to hear that. I'll give you my personal and then I'll tell you what the guidelines say. The guidelines don't because there's nothing to that, so that's clear. In our hospital and with the countless stroke docs I've worked with and all the patients, you do, as you guys know, have a temporary hypercoagulability with the acute infection of COVID. However, the risk of being on even dual antiplatelet, let alone an anticoagulant on top of an antiplatelet risk factor, specifically for the people that are long COVID and at highest risk. So long COVID is well associated with imbalance and falls. That's the last person you want to put on an anticoagulant for risk of bleed. I would say that this is very informal, a single person. I would say this person's probably putting their patients at danger. There's nothing in the guidelines about that.
As my hematologist hat gets put on with that question, that's horrifying to me as well. Really, the longest, if they had a clot, I'd say 3 months of anticoagulation at most, really. And yeah, if they've that far out from an active COVID infection, it's scary.
Also, ischemic strokes are much easier to treat than hemorrhagic strokes. And so, especially traumatic hemorrhagic, that's extremely scary. Yes.
I have a question for Dr. Dolbo. I was curious because in practice and both on your slides today, I noticed that you mentioned for the dual antiplatelet therapy, a range from like 3 weeks to maybe 3 months.
Mm-hmm.
Is that based on the patient's severity? I had a patient recently, and I think they told him 3 weeks, but he was kind of unsure. So I kind of wanted to know if you could give some guidelines there.
Absolutely. So there are 2 trials that were done. And without boring you guys with the trials, they looked at 2 different populations, and they only tested either 3 weeks or 3 months, unfortunately. So we're stuck between the 2. One tested really small lacunar type strokes that were deep, and they said, oh, well, the risk factor for bleed is probably pretty low because it's really small, so we'll throw them on 3 months worth. And then the other one said, well, let's look at big lobar strokes that have an enormous area, and because the risk of bleed is really high afterward, let's only do it for 3 weeks. And both of them, we found, decreased the stroke risk factor, or the stroke risk, compared to controls, so you're stuck between them. So it's typically longer period of time for smaller strokes and smaller period of time for bigger strokes.
Hi, I had a question about, we had multiple times patients will show up after having a stroke 3 to 4 weeks from hospitalization and haven't started it yet. So, happens a lot. It could be they're confused about the discharge orders,
Right.
their medications, which is quite common if they're on more
Right,
than,
especially
right?
if they had a stroke. Like, of course you're not going to know your meds.
My question is, they show up at 4 weeks, they've had, okay.
Yeah, we see that all the time. And in fact, a lot of my interns, they'll be like, well, we put them back on. No, don't put them back on. It's the fact is the biggest stroke risk is in that 3 weeks. It's typically the 2 weeks immediately afterwards is a re-stroke. So adding it back on a month later does nothing but put the patient at slightly higher risk of a rebleed as encephalomalacia comes along and the brain starts to digest itself, getting rid of all the old diseased brain tissue. That's very friable tissue. So if they were to fall and you had just placed them back on, that's going to be a really bad situation. I wouldn't put them back on it.
There was an online question for Dr. Dolbo. What factors do you consider when deciding when to stop a statin for the elderly, both for diabetics and non-diabetics?
I'm thinking of any patient that I've ever had that I've stopped a statin. I've stopped a statin for allergy, for myalgias, but I always start them on an anti-lipid of some sort, a secondary. If they have like a myopathy, you can have a statin-induced myopathy, any sort of significant degenerative or I guess significant injury caused by it. But if the patient's tolerating it, that's what they're on for the rest of their life. I don't take it off based off of, a lot of patients will come in, well, my lipids are down, let me get off of the med. Well, that's because it should be on the med. So I've never taken a patient off of a statin just for no reason.
For those who have a statin allergy or intolerance, is there any data on using ezetimibe?
That's the monoclonal antibody, right? Ezetimibe, absolutely, that's a great one. Yeah, we use that as a secondary all the time. The monoclonal antibodies, the data's not really out yet. And of course, as you saw, you have an aspirin and a statin. If everything's clean, they might not. But it's very rare that the person doesn't need an aspirin for so many other risk factors anyway. So almost never does a patient not come out with a statin and an aspirin. Dual antiplatelet therapy is not indicated after that. However, if they, at least long term, that should never happen. Short term, if you see that, it's probably because there's about a 5 to 10% small stroke risk.
We will get started with our next speaker. Dr. Parker Hughes is a board-certified nephrologist practicing with Nephrology Associates in Clarksville, Tennessee. He earned his Doctor of Osteopathic Medicine degree from LMU-DCOM and completed his internal medicine residency at Norton Community Hospital. He completed nephrology fellowship at the University of Virginia. Dr. Hughes serves as medical director for dialysis units with DaVita Kidney Care and is also affiliated with Dialysis Company Incorporated. He is dedicated to providing comprehensive and compassionate care to patients with kidney disease in Clarksville, Tennessee. Please help me welcome Dr. Hughes.
Hello. I'm going to try and do this quickly and within time here. First, I just want to say that I recognize my job is probably easier than most of y'all's. I get to focus on one little area, and a lot of you guys have a much broader scope. So my goal is just to make your life easier, right, and give you some pearls on how to practice and hopefully communicate with your patients. Possibly. Big green button, right? Okay. Disclosures, it's only that I'm a medical director. However, we are expecting our first child, so if anybody has any conflict of interest that you guys are looking to hire somebody for, just let me know. So throughout this talk, I'm going to be giving examples and using terminology that I use with patients a lot, and so it may seem a little bit simple, but I'm not really filtered by the glomerulus and then completely reabsorbed in the proximal tubule and catabolized. So it doesn't go out into the urine and it doesn't get reabsorbed into the plasma. So it's important to realize that many things are going to affect creatinine levels other than just the GFR. So you have TMP, cimetidine, and famotidine. Important here is if you start somebody on antibiotics like TMP, SMX, expect a little bump in the creatinine. It doesn't necessarily mean that there's an acute kidney injury, although you have to be aware that acute interstitial nephritis can happen with the sulfa drugs. Enhanced creatinine production, high meat meals, and I'll list that in a little bit as well. Creatine, it's a little controversial, but if there's any question, you just have them stop it for a week and then recheck. So we use cystatin C, or I do specifically in certain cases, eating disorders, extremes of muscle mass, obesity, where it's hard to determine what the muscle mass is. Diet, keto diets, right? High protein intake can increase creatinine. Cancer, heart failure, cirrhosis, basically frail patients. You can also use the 24-hour creatinine clearance, but it's cumbersome, patients don't like it, and I really only use it if I'm trying to get somebody off of dialysis. This is not a comprehensive list, just trying to narrow down potential causes and determine whether or not they need to come to the nephrologist. Specifically, previous GFR. Is this an acute drop or is this chronic changes? Medications are the most common cause I see for an acute change. NSAIDs, herbal medications, dietary changes. Important is skin lesions. Right? Is this potentially a vasculitis or a glomerular nephritis? The workup, imaging, the highest creatinines I've ever seen are BPH. And it's very simple. A Foley catheter and it plummets over 2 or 3 days, it's normal. New proteinuria or hematuria. Sterile pyuria is also a big deal because you're looking at any acute or chronic interstitial nephritis at that point. So specifically with damage, proteinuria. Wide screening now in the USA for albuminuria is cost effective because RAS inhibition and SGLT2 inhibitors are very effective. So different types of proteinuria. If it's albuminuria, it's glomerular disease. It's a problem with the filter, and so you're increasing filtration of albumin across the glomerular basement membrane. Overflow proteinuria, it's almost exclusively multiple myeloma, and this is the excretion of low molecular weight proteins, mainly light chains. Now, you can tell the difference because the kidney will filter about 3.5 grams of protein a day, so a PCR greater than 3.5, or protein to creatinine ratio, with the albumin to creatinine ratio less than 1, and this is in grams per gram, would indicate possible overflow proteinuria rather than glomerular disease. And remember to look at the units. My ACRs come out in micrograms per gram, and the PCRs in grams per gram. So this is the different way we categorize albuminuria, and it's the exact same reason why we stage GFR. How I try to conceptualize this with patients, albuminuria versus GFR, is if GFR is decreased, then the glomerulus is shutting down. If albuminuria, it means it's leaking for some reason and there's active damage. The PCR and the ACR can be affected by multiple things. Hematuria and infection increase protein in the urine. Females have less creatinine excretion, therefore the higher ACR and PCR. And then medications, like we mentioned earlier. This is what you really care about, right? The reason why I'm probably here. Diabetic nephropathy, this is the progression of kidney disease in the context of long-standing diabetes. Usually it's accompanied by proteinuria, but not always, and it's the leading cause of end-stage renal disease in the USA. It has a natural history that it generally follows, and the way I try and talk about it with patients is inflammation leads to scarring. So hyperfiltration, this is when the kidney begins to be damaged by the hyperglycemia. It leads to an increase in the screening for proteinuria in type 2 diabetics, albumin to creatinine ratio because it's a glomerular disease at the time of diagnosis, and in type 1 diabetics, usually about 5 years after the diagnosis. Certain specific risks for progression, uncontrolled diabetes with an A1C greater than 7, male sex, albuminuria, which is the hyperfiltration, uncontrolled hypertension as well. So these are a couple studies that really defined how we treat diabetic kidney disease. First, in 2022, the RENAL study, so losartan versus placebo in controlling proteinuria and blood pressure, 28% reduction in ESRD. Decrease in the decline in GFR was very significant, and reduction in first hospitalizations. However, there was no difference in mortality. The SGLT2 inhibitors, there are 3 of these studies that had a major impact. The first being Credence, 4,400 patients, type 2 diabetics with albuminuria, 30% relative risk reduction in the composite of ESRD, doubling of creatinine, and renal and cardiovascular death. DAPA-CKD is dapagliflozin. The big thing we found out here is that there's consistent benefit amongst all CKD, not just diabetic. And we'll go into the mechanism of that a little bit later. So IMPA-CKD, again, showing the same thing. Basically what this means is I will try and get any SGLT2 inhibitor that insurance will pay for. Finerenone, so this is the non-steroidal mineralocorticoid antagonist. So on top, it's basically a replacement for the spironolactone and the eplerenone, right, with fewer side effects because it's non-steroidal. The big thing is the hyperkalemia-related discontinuation. It has very specific dosing based on baseline creatinine and GFR. That's very easy to find. But a potassium of greater than 5.5 means you don't start it, and also discontinue. But there are also specific instructions on when to restart it. Last summer, we now have evidence that to slow the progression of CKD, we can use GLP-1. So there was a 24% risk reduction in composites of kidney failure, greater than 50% eGFR decline, and death from kidney and cardiovascular causes in this study. So when you're trying to treat the diabetes and chronic kidney disease, this is the next way to go. Most AKIs, when you start one of these, are pre-renal because of the GI side effects. There is a slight risk of AIN, but it is very low. So high blood pressure and chronic kidney disease. The goals are the big component here. Chronic kidney disease patients, it's 120/80. Now in dialysis and transplant patients, we allow it to be a little higher, but this is only a 2B recommendation in the guidelines. Dialysis patients are complicated when it comes to blood pressure because volume plays a much higher role. And we do a lot of different things in the dialysis unit to try and help with that. Everything from changing the sodium in the bath or the dialysate fluids to being more aggressive with ultrafiltration. Also important, different medications come out in dialysis more. So ACE inhibitors come out a lot more than ARBs. Also, metoprolol, heavily dialyzed. Carvedilol is not. If there's a question about blood pressure in a dialysis patient, just call the nephrologist, because we tend to do specific things and we change a lot. The top 3 medications that I use is ACE and ARB, but then hydrochlorothiazide or chlorthalidone. They actually are very effective in chronic kidney disease. And then the dihydropyridine, calcium channel blockers. Lifestyle modifications, you guys are probably all working on this. Big point that I wanted to hit, there is a natural decline in GFR with RAS inhibition and SGLT2 inhibitors. But that's actually a good thing. So serum creatinine increase of 30% above the baseline, it actually improves the long-term outcomes. However, if you've got a GFR reduction of greater than 30%, that's problematic, and we need to make sure that that's just the medication, there's nothing else going on. Is there damage when this happens? So particularly in the SPRINT trial, there were no tubular biomarkers that would indicate tubular damage whenever there was starting an ACE or an ARB. One of the reasons why it happens is you have a decrease in the intrarenal or intraglomerular pressure. The way I try and explain it is that whenever you block angiotensin, you decrease sodium absorption, decreasing in volume, and then also by decreasing aldosterone, you decrease the GFR from dilation of the efferent arteriole. SGLT2 inhibitors increase delivery of sodium chloride to the macula densa, and the result of that is that you get, the kidney is able to control afferent arterial dilation and constriction. You get an increase in the constriction of the afferent arteriole because the kidney is interpreting this as really good blood flow. I'm going to kind of rush through these because there's a good resource I'll list at the end, but a couple of quick points. High potassium. There's a lot of potassium in the body, but very little in the plasma when we're measuring it. So whenever we've got hyperkalemia and we're trying to get rid of it, it will take a little bit of work. Main causes are the medications, metabolic acidosis, hyperglycemia, hyperosmolality draws potassium out of the cells. Treatment, this is a big one. Whenever your GFR is stable, right, or at least higher, usually stage 3A or 3B, you can get rid of it with diuretics, loop diuretics specifically. It's the most effective way to do that. However, when we're looking about getting rid of it through the gut, patiramir, sodium zirconium, these are the best ways to do it. Fewer side effects, you're not going to give them diarrhea. However, expensive. Sometimes insurance covers it, sometimes not. Mineral bone disease, complicated, very complicated, but the basics are you have 25 hydroxylase vitamin D. It goes to the proximal tubular epithelial cells. It's converted to calcitriol or 1,25-dihydroxycholecalciferol, goes to the gut and the kidney, reabsorbing calcium in the kidney, and then absorbing calcium from the intestines. If this is declining, the kidney function is declining, you're not going to be able to make this conversion to calcitriol. Parathyroid hormone is going to increase with the lower serum calcium, increasing bone turnover through increased osteoclastic activity. So if the parathyroid hormone, when we measure this, is still elevated despite repleting vitamin D, we use calcitriol. Anemia, erythropoietin deficiency is the most common cause of anemia in chronic kidney disease. So practically speaking, when this occurs, we have to involve hematology. Right? They're the ones who can get the erythropoietin stimulating agencies in the outpatient. Once they're on dialysis, we give it to them all the time in the dialysis unit. Hyperglycemia or hyperuricemia, gout, much more prevalent. Xanthine oxidase inhibitors are safe. Just make sure the dosage is correct for the GFR. And for acute gout, just trying to stay away from the NSAIDs. So different things can delay the progression of chronic kidney disease. Basically, I always say food is medicine. It's the first pill you take in the morning. Lifestyle is the same as with high blood pressure and diabetes. Using specific medications like the ACE, the ARB, the MRAs, SGLT2s, protein intake, this I take with a grain of salt, because if you have an obese diabetic, increasing protein and fat intake means decreasing carbohydrate intake, which gives you all the other benefits that come along with decreasing high blood pressure, decreasing weight. So most of the time, I don't restrict them if they're in stage 3. But these are the guidelines and the recommendations. Common pharmacological issues that I see a lot. Folks are on meloxicam, Celebrex, because they all have osteoarthritis. You can use the diclofenac topical, but NSAIDs can be pretty dangerous. Antidepressants, the dopamine agonist, you get a lot more side effects from those, but sertraline has a good safety profile. Metformin, usually less than 30, a GFR less than 30 is when we try and stop that. Baclofen, a lot of side effects. Transplant patients, their immunosuppression has a lot of interaction with medications. So it's important to double check that before you end up starting anything. And herbal treatments, that's a big one. Real quick on pregnancy. So dialysis patients can become pregnant, and this is pretty dangerous because it requires daily hemodialysis. So I highly encourage contraception in these situations. Also, post-transplant pregnancy is possible, and it can be coordinated with the transplant team. They can change the immunosuppression medications to make it safer. And so there is planning for that in every transplant program, probably. But the assessment of kidney function changes in pregnancy. So cystatin C is released by the placenta in response to the ischemia. And using the CKD epi-creatinine clearance equation, you underestimate GFR by approximately 40%. Increase in volume results in increased intraglomerular pressure, increased filtration. So we changed the definition of normal proteinuria to less than 300 milligrams in 24 hours. And in a patient with normal kidney function and pre-pregnancy, a creatinine greater than 1.1 or doubling of the creatinine, even if it started off as 0.4 and now it's 0.8, needs to be investigated. Specific studies that supported this, retrospective in 2015 in the American Journal of Kidney Disease, we found that with a GFR less than 60 and a creatinine of greater than 1.2 in the first trimester, you have an increase in preterm, an increase in C-sections, NICU admissions, low birth weight, and infant death. However, no increased risk for preeclampsia, small for gestational age, or maternal death. Now in 2023, this study also came out in the Journal of American Society of Nephrology. It's a single center retrospective study out of Ontario, but what we learned is that there's, with this severe maternal morbidity, this includes hemorrhages, cardiac complications, sepsis, AKI, DIC seizures, preeclampsia, and HELP, and acute fatty liver. Proteinuria and GFR are directly correlated with these events. Things that need a nephrology consultation, acute decline in kidney function. I usually like to see them once they get to CKD stage 3. Reason being, our goal, push off dialysis as far as we can. Proteinuria, hematuria without a urologic etiology, resistant hypertension, because certain medications will be more effective, and chronic kidney disease is a cause of resistant hypertension. Anytime you're concerned for glomerular nephritis or have electrolyte problems, and pregnancy for sure. Also, anytime you feel uncomfortable or you just want to send them to us. And we're pretty nice for the most part as a specialty, so you can always call if you need somebody in quickly. these are really good sources for information. The Kidney Disease Improving Global Outcomes, KDIGO, has guidelines for a lot of different things associated with kidney disease, including mineral bone disease and anemia, diabetic kidney disease, and hypertensive kidney disease, in addition to just chronic kidney disease. KDOKI, this is the American version. And KDOKI and KDIGO also have really good summaries of their guidelines if you want to just go through it briefly. The National Kidney Foundation, great information on diet for patients. The American Journal of Kidney Disease has a curriculum in nephrology that's short and condensed, 130 different articles, but very specific things. Nephrology is hard to get a hold of. Really good resource, and you do not have to pay for membership with that. Hopefully, I didn't go too far over, right, but those are my sources. I hope that makes life easier for you eventually.
And we will save questions for Dr. Hughes until after the next speaker. Our next speaker is Dr. Mallory Reeves. Dr. Mallory Reeves is an osteopathic physician with primary training in pediatrics. She completed her osteopathic medical degree at LMU-DCOM in 2015 and was a recipient of the Army Health Professionals Scholarship. She completed residency at Tripler Army Medical Center in 2018, then worked as a pediatrician with the United States Army around the country until she was honorably discharged. In November 2022. She then returned to Middle Tennessee and works as a general pediatrician at Manchester Pediatrics Clinic. She's also a clinical adjunct faculty member for LMU-DCOM. She likes to spend her spare time with her husband and 2 children outdoors on a hobby farm. Please help me with Reeves.
Good morning, guys. How are y'all this morning? I apologize. Bear with me. Notes that I'm pulling up. As she said, my name is Dr. Mallory Reeves. I'm a general pediatrician now, but I definitely went to DCOM back in 2015 is when I graduated, so I still consider myself definitely part of the DCOM family. We're going to get this started here momentarily. If you see children running in and out of here, I apologize. Those are my wild children. And I feel like it's kind of appropriate given them a pediatrician. Just bear with us on that one, okay? All right, so we're going to get this started. All right, so we're talking about common childhood viral syndromes, okay? So from the get-go, financial disclosure, I don't have anything to share or report there, okay? Better? Can you hear me now? All righty then. Going on, goals for this topic, I'm just going to be talking about 12 very common viral illnesses that we see in the pediatric population. We're going to highlight the key clinical features of each of those because in pediatrics, everything can look very similar or just alike. So we're going to kind of narrow that down a little bit for you, okay? We're also going to be talking about management and prevention strategies of these viral illnesses, and we're going to go over potential complications of some of them as well, okay? All right, so common characteristics of most viral infections, we think of fever. That does apply to most of them. Respiratory symptoms are a very common thing, such as cough, congestion, runny nose, those type things. Can have a rash, can have GI symptoms with it, such as vomiting or diarrhea. I'm going to be kind of breaking down our viral infections by these 3 main things: respiratory, rash, and GI symptoms, okay? Other common characteristics for viral infections are these seasonal appearances. Usually we see certain things in spring, certain things in fall or winter. We've seen a lot of shifting of that, of a lot of our viruses since the COVID-19 pandemic. So we'll be talking a little bit about that as well, okay? Transmission is typically one of 3 modes for children: respiratory droplets, fecal, oral, and or contact, okay? Moving on. upper respiratory viral infections. These typically are lasting about 7 to 10 days duration. Typically, all we're doing is supportive care for those, okay? Please do not give antibiotics for upper respiratory infections. So your common cold, typically, it's acute self-limiting viral infection, usually due to rhinovirus, enterovirus, adenovirus, one of those two. Parents always ask us, hey, which one is it that it's causing? Honestly, we treat them all the same, so I don't do any additional testing. Please don't do a ton of testing for that. But I get a lot of patients that want testing. Please don't do it. Symptoms, you see sneezing, nasal congestion, runny nose, sore throat, hoarseness, all the classic cold symptoms that we think about. Fever can be associated with some of them, not all of them. Usually it's going to be low grade in pediatric population, okay? For your older children, that fever is typically less common for them, okay? Diagnose again, we want to clinically diagnose that. If you're concerned about focal lung findings like a viral pneumonia or something, you want to consider getting a chest x-ray, but that's about all the testing that I usually recommend on those. Transmission, obviously, respiratory droplets, hand contact. Please practice our good hand hygiene to prevent that from happening. And then cleaning surfaces, wipe down thoroughly. Treatment for these, like I said, supportive care on that. So for our infants, we're doing nasal suction and saline for them. That's pretty much all you need to do for them. Supportive care and a whole lot of cuddles and hugs with them, okay? Otherwise, you can have fever reducers as needed. Potential complications that we've run into with these children, ear infections, asthma exacerbations. Sometimes we can see a sinus infection, pneumonia, specifically a viral pneumonia, can definitely happen for us. When we're looking at the viruses that cause these, 50% of most common colds are going to be due to your rhinovirus. We do develop some immunity to those, but because there's over 100 serotypes of rhinovirus, you're not going to get very far with the immune system that you do develop from the one virus you encounter, okay? Rhinovirus actually presents year-round as well, so it's got bimodal peak distribution, so it typically peaks in September as well as in March and April timeframe. Typically a smaller peak there in the springtime compared to the fall, but that can happen. We're actually seeing less of this bimodal distribution with a lot of these viruses, though, since COVID pandemic happened. We're kind of seeing it disperse all throughout the whole year, okay? The peak infectious period for rhinovirus shedding usually peaks around the 3rd day after inoculation. And that's typically when you're seeing those worst symptoms. About days 5 to 7, things are improving or completely gone. Enteroviruses that cause this, we typically think of echovirus or Coxsackie virus. They make up less than 5% of what causes common colds for us, okay? They typically occur year-round, but mostly peak in the summertime. Adenovirus is usually less than 5% of reasons for common cold as well. Peak season for that is usually September through May timeframe, okay? So moving on to next. Influenza, everybody's heard about it, everybody thinks of it. The main types that we think of, types A and B, y'all know what flu's like. It's miserable. You feel like you got ran over by a truck. So it's a sudden onset fever, usually a higher fever in children. I think of like 103 range for children, okay? They have body aches, they have fatigue, sore throat, all those things. We're diagnosing that clinically. You can do rapid testing if you want, but that's not something you have to do. Transmission is via respiratory droplets and hand contact. Prevention, annual flu vaccine, of course. Hand hygiene, you want to decontaminate the environmental surfaces. Treatment for this, we usually recommend the Tamiflu. We usually say to only do that within the first 48 hours of symptoms if they do occur. Otherwise, you want to do fever reducers, suction, saline as needed, okay? The variability on prescribing Tamiflu is heavily debated in the pediatric population. A lot of people don't even give it oftentimes. There was a cross-sectional survey done back on pediatricians in 5 different subspecialties of pediatrics back in 2024. And that was done at 7 different U.S. hospitals, children's hospitals in the U.S. Showed consistent non-adherence and non-compliance with what the AAP was recommending. And so there's definitely more research going into that on exactly clarifying the guidelines on when you should and should not give Tamiflu, because pediatricians in of themselves are not prescribing it routinely at the same time every single time, okay? So more to follow on that one. Looking at COVID-19, I'm sure you're all tired of hearing about COVID ever since the pandemic. I got so sick of hearing about it when I was in the Army during that time. Working the COVID tents was definitely getting old. But we're going to touch on that just a little bit here. In children, it's actually very, very mild. Like, we really don't have COVID huge complications in pediatrics compared to adults. You can see fever, cough, shortness of breath. Honestly, it looks like colds usually for us. Occasionally, they will complain of the characteristic loss of smell or taste, but it's usually more of our adolescent population than the little ones that are complaining of that. Diagnosis, you can do PCR testing. Lab testing is necessary if you want to confirm it, but clinical suspicion, we treat them all the same. You don't have to do it. You can just have suspicion and supportive care for that as needed, okay? There is pre-exposure vaccine prophylaxis, hand hygiene, decontamination to help prevent it as well. Antivirals, you can sometimes try out. There's more studies going into that about giving that to the immunocompromised children, but it's not consistent. And then potential complications of COVID-19 include the MIS-C, multisystem inflammatory syndrome of children. I've honestly only seen a couple of cases of it myself personally. It is very rare, but it can be a very severe condition. It's thought that some children are predisposed to MIS-C because of genetic variants that play a role in it. One study that came out of Brazil back in 2023, I believe it was, identified that pathogenic or likely pathogenic variants, and they had 30 patients with MIS-C, 29 out of the 30 showed some genetic variations that were all pretty characteristic of it, okay? And then they're trying to isolate specific genes that are more predisposed to it, so more ongoing studies happening with that. Okay. Looking at RSV, this is like our bread and butter in pediatrics, so typically consists of cough, coryza, conjunctivitis, and rhinorrhea. It occurs, pretty much almost all children are infected by 2 years of age. Reinfection can be common. Older children, though, again, comes off as a common cold. Younger children or infants, those are the biggest ones that we're worried about with RSV because it can easily put a lot of them into the hospital. We diagnose this clinically. You can do further PCR testing if you want, but not something we have to do. This is transmitted by droplets, direct hand contact, and then we also see a seasonal outbreak, typically in the fall to early springtime is usually when we see that outbreak, although again, that distribution is kind of shifting a little bit since the pandemic, and we're kind of seeing it occurring all throughout the year now. And with that, we have the RSV vaccine available for prevention. It's kind of been a beautiful thing in the pediatric world. Used to, we only had the RSV vaccine, such as Synagis, available for those high-risk populations, so like your extreme premature infants and everything. But now we actually have Beyfortus, which is a beautiful medication that has been great at helping out preventing RSV complications, keeping children out of the hospital for us. Beyfortus, usually it's a vaccine that we're giving either right at birth or within that first week of birth. If they're born in the summertime, we're giving it right there at the beginning of RSV season, so like October timeframe. And that medication is actually just a one-time thing, and it lasts for about 5 to 6 months is the thought there, okay? And children can get that all the way up to until 24 months of age. The AAP actually only recommends giving it past 8 months of age if they have certain high-risk categories, but the manufacturer does approve it up to 24 months for us, okay? So you can use it pretty much in all children up to 24 months. It's great compared to the old Synagis in that the Synagis you had to do like an injection, IM injection every single month for 5 months, the entire season. This is just a one-time thing, so parents are like buying into this a whole lot better. So we're seeing a lot more success with that, okay? Moving on. All right, now we're going to talk about viral exanthems. This is the part that most people hate because they're like, I don't know what this is. So the timing of the rash in relation to when their other symptoms start are really going to help you with this, okay? So going on, erythema infectiosum, aka Fifth disease, or slap cheek is another name for it. This is due to parvovirus B19. Typically, you see that slap cheek on the face and then a lacy rash on the entire body, okay? This is most common in school-age children. It is transmitted via respiratory droplets, vertical transmission, and hematogenous transmission. preventing, again, like other viruses, good hand hygiene, cleaning your surfaces. You want to avoid this in pregnant individuals. So if you have a sick child with this, we typically recommend to keep them at home from school, especially if their teacher's pregnant or something like that, because it can cause complications with the fetus. Treatment, supportive care, otherwise for the child. Potential complications, although rare, aplastic crisis and sickle cell kiddos can happen. And then the fetal hydrops is what I was mentioning about the pregnancy, okay? All righty. Roseola, aka 6 disease. This is due to HHV 6 or 7. There's other viruses that cause it as well. It's just that HHV is the most common. This is typically a high fever, 103, 104 range. I've seen lower ranges as well, but it doesn't surprise me when we're hitting 104. And then that fever lasts about 3 to 5 days, and then all of a sudden it abruptly stops. And bam, that rash starts up, okay? And it's usually described as an erythematous blanching rash. It can be macular or maculopapular, okay? And it usually starts on the torso, like the trunk area. It can be front or back, and then it spreads out to the rest of the body, okay? This is most common in our infants starting around 6 months all the way through the toddler years, so I usually say about 2 years of age. We can see it in a little bit older kiddos, but it's less common there. It's found sporadically throughout communities without a direct known exposure oftentimes, but we do know that it is transmitted via respiratory droplets as well as fecal-oral routes. So if you got a little one in diapers, we usually say, hey, don't let everybody change diapers. It needs to be like one individual in the home. If they're in daycare, limit to one individual worker there changing the diaper rather than a whole lot of people doing it, potentially decreasing the spread of it. Hand hygiene is the biggest thing. Supportive care is the other big thing. Potential complication of this is febrile seizures, okay? That is fairly common for us to see as well. All right, and then looking at this next one, hand, foot, and mouth disease, it's usually due to a Coxsackie virus. Most commonly is A serotypes. These pictures, interesting, is personal. This is actually my son's pictures when he had it. So it can cover everywhere. So symptoms, painful oral ulcerations, rash on the hands and feet, and the interesting thing about this, it includes the palms and soles, okay? Most rashes in the pediatric population are not including your palms and soles. They usually spare those areas. This one actually includes it. The rash is usually described as macular, maculopapular, can be a vesicular rash as well. Should not be in like large clusters like herpes virus though, should look a little bit different of that. Usually falls in the category of daycare age range, typically less than 5, but I've seen it in a lot of school-age children as well. It is usually spread by fecal-oral route, oral and or respiratory secretions. Biggest thing is hand hygiene and supportive care only. Interesting fact about Coxsackie A16 and enterovirus A71 are the most frequently associated viruses, serotypes associated with hand, foot, and mouth. And since 2008, we've seen the Coxsackie virus A6 increasing in numbers as well, and that's causing more of an atypical hand, foot, mouth presentation. We're seeing a lot of fingernail sloughing off of the fingernails when they get it infecting their hands, and so these kids are losing their fingernails. They grow back, don't worry, but it looks a little bit rough when they get it. And so this particular serotype A6 of Coxsackie virus is more heavily associated with that versus just having the rash everywhere else but not affecting the actual fingernails or toenails. Okay. Moving on. Potential complications for that. Dehydration is really our biggest one. The other things, I've actually never seen any of those as a complication of hand, foot, and mouth, but those are potential complications in rare instances. Measles, this is the hot topic in our world these days. Rubeola symptoms, cough, coryza, conjunctivitis, Koplik spots, diffuse rash, and fever. It can occur in all ages, especially the immunocompromised and or unvaccinated. Transmissions via person to person and or airborne. Obviously, we want our MMR vaccine to help out with that. Treatment is just supportive. There's not any great medications out there for it. It is highly contagious. Following exposure, approximately 90% of susceptible individuals will develop measles. So pretty much everyone that's susceptible to it gets it if they're exposed to it. Period of contagiousness is anywhere from 5 days before the rash starts to about 4 days afterwards. So about that week before and the week prior of that rash, the child's contagious. Incubation period is anywhere from 6 to 21 days. Average is thought to be about 13 days there. Clinical stages, just going a little bit more in depth on this because of it being a hot topic. Clinical stages, like I said, the incubation period is listed there. Prodromal period is usually about 2 to 4 days, although it can be up to a week. And that usually is consisting of the fever, cough, conjunctivitis, coryza, all those things. And then the Koplik spots will usually start during that time frame too. And those are just tiny white, gray, or like a bluish colored elevations within inside, usually the buccal mucosa. And it's usually red right there at the base around it, okay? These typically are measuring anywhere from 1 to 3 millimeters, and typically more so towards the back of the buccal mucosa, but they can actually be any and all the places in there, okay? Can affect the hard and soft palate too. So they really describe it, the buzzword on that is salt and pepper, so like grains of salt on a red background type of situation. The rash period, when we have that, it's described as an erythematous maculopapular blanching rash, okay? That begins on the face and then spreads down and out, all right? So the way my old infectious disease attending in residency, he was like, think of a bucket of paint and just dripping down, and it kind of goes that way, so. And like I said, the rash usually begins about 2 to 4 days after the fever onset, and then with the fever peaking about 2 to 3 days after the rash appears. And then other associated things, conjunctivitis, pharyngitis, and lymphadenopathy occur with that. Recovery period, rash typically lasts 6 to 7 days, then fades in the order it appeared. And then you can see the skin peeling, desquamation, severely affected areas. The cough can persist for about 1 to 2 weeks after the rash resolves, okay? Moving on to varicella, chickenpox, just because we are seeing a lot of unvaccinated children, chickenpox is definitely starting to make more of a predominance again, similar to measles as well. So this is due to varicella zoster virus or herpes virus subtype. Vesicular rash in crops, fever, and malaise are common issues with it. The rash is described as generalized vesicular, and it's usually itchy for them, and it occurs in crops. Infections, it is infectious from 2 days before the rash occurs until the vesicles are completely crusted over, and that's all vesicles, not just the first ones. They all have to be crusted over to be considered non-contagious. This can occur in all ages. Again, immunocompromised and or unvaccinated are the biggest ones. Transmissions via aerosolized droplets or direct contact with the vesicle fluid from skin lesions, okay? Varicella vaccine actually first came around in 1995. I actually remember that. And then it's recommended for all children by 5 years of age at this time. So, and the reason for that is this is a highly contagious virus. Secondary household attack rates occur in greater than 90% of susceptible individuals. So definitely recommend getting that vaccine, okay? So treatment, excuse me. Treatment, we talked about this, mainly symptomatic care, supportive care, and immunocompetent. For those high-risk infants or children, we'll sometimes give them acyclovir, so like premature neonates or infants less than 7 days of age. Immunocompromised children or children with systemic or CNS disease. IV acyclovir for premature neonates and term neonates less than 7 days. Or if there are other severely high-risk children, we'll give IV acyclovir. For all other that meet the immunocompromised criteria but are not considered a higher risk there, we'll do an oral acyclovir for them, okay? The varicella zoster immune globulin, that can prevent from developing or lessen the severity of the disease. So that's actually recommended for those that cannot receive the actual varicella vaccine, okay? But you want to give that within 10 days of exposure. All right, moving on. Okay, we're kind of getting into viral gastritis at this point. Gastroenteritis, our other third main thing that we see in pediatrics. So the two big ones that I'm going to be talking about, we've got rotavirus and norovirus, okay? Rotavirus, you're going to have watery, non-bloody diarrhea, vomiting, and fever. Typically in our little ones, so like toddlers and younger, so less than 5 years of age. This definitely happens in our unimmunized children, 6 months to 2 years of age. It is transmitted via fecal-oral route and peaks during the cooler months in temperate climates, but can be year-round in tropical regions. When I was stationed out in Hawaii, we saw it year-round out there for a lot of unvaccinated children, so we had them in the PICU all the time. And then treatment is just supportive and make sure that they stay hydrated. That's usually your biggest complication is dehydration with it, okay? Is associated with seizure activity sometimes for some children. The exposure time of this is usually less than 20 minutes. Actually, you only have to be exposed for like 20 minutes before you potentially are considered to be at risk of it. Incubation period is less than 48 hours usually. The viral shedding in the stool lasts for approximately 10 days, so you are considered infectious at that time. Norovirus, our other one, nausea, non-bloody, non-bilious emesis, non-bloody watery diarrhea is what can happen with it. You can see a lot of abdominal pain, fever, and headaches is a big component of it. Vomiting is more prominent here than other gastroenteritis usually, but other than the vomiting, usually these are not as ill-appearing as like rotavirus can be. This can occur in pretty much in all ages. You hear about it in the adult world too, but it doesn't target like our rotavirus does with our younger kiddos. This is also fecal-oral transmission, airborne droplets from the emesis if that happens. It is transmitted year-round, but thought to peak during the winter months in it, okay? Prevention, hand hygiene, it is not killed by alcohol, so like classic old school soap and water is your BFF here, okay? Treatment, supportive care, rehydration, and then dehydration is your complications. All right, so CMV, we're talking about this here. So CMV is cytomegalovirus. It's a member of the herpes virus. No known serotypes. Mostly asymptomatic. It gives you mono-like symptoms for you, so like fever, fatigue, adenopathy, pharyngitis, hepatitis. It can occur in all ages. Transmission, in pediatrics, we see it a lot in utero, vertical transmission, perinatal, so mom secretions during delivery. Breast milk can do it, close contact, family members around them. Sexual transmission for our older population, like our teenagers. Blood transfusion and organ transplants is another way, so this can be transmitted in all sorts of ways. Breast milk is one of the most common modes of transmission in postnatal period. Prevention for this is freezing, thawing, or pasteurization of that breast milk. That'll help prevent it. CMV safe blood products. Otherwise, it's hard to prevent just because we never know where it's at. Treatment, antiviral therapies such as ganciclovir or valganciclovir for preterm or very low birth weight babies, or the immunocompromised. Otherwise, you just support them through it, okay? The biggest complication for that is hearing loss for congenital CMV. So nowadays, any infant that fails a hearing test, it's actually recommended to get CMV testing on them if they fail that newborn hearing screen. So that's some of the things we're implementing in pediatrics these days. Epstein-Barr virus, EBV, member of the herpes virus. We actually see this fairly frequently. Mainly, we think of infectious mononucleosis, so just malaise, headache, fever, cervical lymphadenopathy, tonsillitis, pharyngitis, those type things with it. Splenomegaly is a big complication with it. Some kiddos are actually asymptomatic with this. That is potential as well. This can occur in all ages. It's transmitted via oral secretions, bodily fluids, prevented by hand hygiene. Treatment is supportive care. You want to avoid strenuous activity for at least 3 weeks after infectious mono onset. So all those teenagers, like, they have to take a break from playing their sports for a few weeks to make sure we're not having any complications with the spleen or any other issues. Potential complications with this include rash, airway obstruction, splenic rupture. It's associated with actually multiple other conditions, multiple sclerosis, oral hairy leukoplakia, Hodgkin's lymphoma, Burkitt's lymphoma, and T-cell lymphomas as well. All right, so the sum of all of this for your common childhood viral illnesses, just wash your hands. Just have them wash your hands. Easier said than done when you're dealing with the little population, but that's really the best thing. And then just public health education, making sure families and parents and daycare teachers, all of them are aware of how these things are transmitted and how we can prevent them. Vaccinations, one of the biggest things there, and I've listed routine vaccination schedules for the common vaccines that we have there. as well as the link for the CDC website there that you can look at further on your own time, okay? All right, so final tips, just most viruses are going to be self-limited, but they can have serious complications, right? So that's why we want to see these kiddos and make sure that they're doing okay with them. We want to focus on appropriate hydration and maintaining fever control for these viral infections. Those usually are causing more of our issues in the pediatric population, so just making sure the parents know what they should do and should not do, okay? Prevention is really key for us. We want to do those isolation precautions and hygiene, appropriate hand hygiene for each of these. Vaccination can prevent multiple severe illnesses in pediatrics. Please, please, please encourage our vaccines. I feel like I fight that battle on a regular, so certainly do not discourage the vaccines. Proper education really can change a lot of minds for that. And then early recognition for these conditions definitely improves the outcomes so that we can provide them preventative care as well as proper education for our parents, keeps them out of the hospital for us, okay? And then that is my list of resources, and I appreciate your time. This is me and my kiddos and stuff. Let me get there. There we go. So if anybody has any questions, I think we got a couple minutes.
We have about 2 minutes for questions.
For fifth disease, how do you counsel families where the kid has it and the mom is pregnant?
Ah, gotcha. That's a tricky one that we deal with. So ideally, you want to try and keep them separated. Mom needs to have close follow-up with her OBGYN so that they can also continue monitoring fetus throughout the pregnancy, remainder of pregnancy. I've had a few instances of that. So I try to separate them, which is very, very difficult when they live in the same household. But ideally, you want to, almost like the COVID days when we were self-isolating to one room and somebody else was self-isolating to another room. That's kind of what we do. We actually do the same thing for kiddos on the mother-baby unit when we're dealing with like flu or COVID when that was going on. We would have to self-isolate. So that's about the only thing you can do, and then mom just needs very close follow-up with their OBGYN to make sure we don't have those complications. Okay, good question.
I've seen different providers give different school excuse times for hand, foot, and mouth and mono. So,
Yeah.
like, what is your timeline for mono and hand, foot, and mouth on
Gotcha.
return to school?
Yeah, so mono, obviously no fevers or anything like that for at least 24 hours. They have to be participating in non-strenuous activities, so they can't do PE or anything like that for several weeks. But otherwise, if their energy level is back up and they're otherwise showing okay vitals, normal vital signs for me, and no fevers appropriately, I'm okay with them going back once they have the energy and stamina to go back up. So sometimes it's just a few days, sometimes usually it's more so a week for mono is what I find myself doing. That go to the classroom, not to go to PE or anything like that. PE or any extracurricular sports is usually like a month out, depending on how they're doing. So, and then hand, foot, and mouth, depending on who you talk to. So typically the lesions should not keep them from going to daycare or school or anything like that, okay? It's more so of, do they still have fever? Are they staying hydrated? Are they able to take fluids and eat okay? Because the teachers aren't gonna have time to pay attention to those things, right? And so those are really the biggies. So they gotta be fever-free for 24 hours. Some daycares do instill requirements that all the lesions have to be covered, crusted over, before they'll allow them to come to school. But honestly, these lesions can vary on how long that they last. And so I don't use that as a criteria for mine. And if you look at the AAP, they don't recommend that you solely count that as a criteria for them. Okay.
For the sake of time, if there are additional questions, you can submit them to Amy, and we will post all of the answers online. We'll go ahead and move forward with the next speaker. Thank you, Dr. Hughes and Dr. Reeves.
Thank you.
Dr. Michael Douglas received his medical degree from LMU-DCOM in 2012. He served a urologic surgery internship at UMDNJ Kennedy University Hospital and urologic surgery residency at Rowan University in Stratford, New Jersey, which is now Jefferson Health, New Jersey. He is board certified in urology and is on staff at Methodist Medical Center. Board certified in urology and is on staff at Methodist Medical Center in Oak Ridge, Tennessee. He is the current president of the Tennessee Osteopathic Medical Association and serves on multiple committees and boards. In his spare time, he enjoys spending time outdoors with his family and playing tennis. Please help me welcome Dr. Douglas.
Well, good morning. How's everybody doing today? All right, we can work with that, I think. Thanks. All right, we can work with that, I think. Thanks for having me. I appreciate it. I've given this lecture in different parts and that sort of thing over the years, and have kind of added some things and taken some things away. So you may have heard some of these things before. I know we have some people probably getting drinks or restroom. How many people, out of curiosity, had a formal urology rotation maybe in their residency? Or okay, that's actually more than I thought, so that's good. Awesome. I am about to start helping with the Methodist Medicine family residency clinic down in Oak Ridge, so I'm happy about that. So I have no disclosures. I am a shareholder in our Stone Center, the ESWAL machine, just FYI. I don't think I talk about that though in the talk. So these are the objectives of what we want to do today. We are going to spend a little bit of time at the end talking about some more controversial things, PSA screening, as well as testosterone, which are kind of the hot topics these days. So a little bit of humor for urology there. First thing, urinary retention. These are the things that I kind of want to discuss, just things that you would call us about, or that we would get, you know, if you're covering the ER in the middle of the night, things that you would want to give us a call about. So urinary retention, we use that number 350 cc's as a guideline. It's not, you know, it's not set upon, but we want to see those patients with symptoms. I've seen people with 3,500, 3,800 in their bladder, so 350 cc's may not be very high for them. So you kind of want to get a history and make sure, obviously, that ultrasound there is just a picture of their bladder with the prostate right underneath that. This from a lot of different reasons, as you can see there. I want to point out at the bottom the constipation, immobility. In the hospital setting, this is probably the number one thing, that and anesthesia that they've had. So make sure your patients are having bowel movements, because that can certainly cause them not to be able to urinate very well. A lot of complications. This I want to point out here is autonomic dysreflexia. If you've ever seen this, it's kind of scary. I've seen it twice, and it's a little scary. You want to empty that bladder as soon as you can. Put the nitropase the level of the lesion, and you can give them nitrogen. Post-obstructive diuresis, generally nephrology colleagues. However, patients with bilateral hydronephrosis, those with a solitary kidney, are all at risk for developing post-obstructive diuresis. I give 75% of the volume that they lost in half normal saline. So you can always check these patients' labs and phone a friend to know, which is what I usually do. Foley catheter. 18 French Foley catheter. I joke all the time that I can get almost anything done with a Foley catheter, then 18 French Coude and some Lidojet. So if you're not using Lidojet, please get it on your formulary. It will make your life a lot when you're trying to put in Foley catheters. Of course, that goes right down the urethra. But 18 French coude in a male, if they are concerned about a stricture, you can go smaller. With the 14 French, and also you can use that silicone catheter. It's a little bit more stiff and it helps you to kind of push through that. One of my friendly reminders is please document the volume of urine somewhere, or let someone know so that we know kind of when to take that catheter out. We get a lot of follow-ups from the ER, and we don't know how much came out. You know, the patient says, well, it was kind of full, or I was hurting, or, you know, that sort of thing. It kind of gives us information about when to take that out. You can put them on Flomax when you put the catheter in, and of course let young guys or those who are sexually active know about retrograde ejaculation. So this is a coude catheter. That little tip there is curved. That helps to navigate right past the verumontanum as the urethra goes upward to go through the prostate. So it makes sure that tip is upward at 12 o'clock, that it's not twisted to either side, or certainly not down, or else you're going to go right through the back wall of the urethra, potentially into the rectum, which is unfortunate. I've seen that a couple of times before. But coudes are your friends. They're not hard to place. You just keep the tip up. Gross hematuria was really only emergency if the patient isn't able to urinate. So if you give us a call and you say, hey, this patient has gross hematuria, one of the first questions that most urologists are going to ask is how much is in their bladder and do they have clots. So clots are concerning if they're not getting out. You always want to look at the bag. You rather don't want to look at the bag. You want to look at the tube to see what that urine looks like, because the bag can be sitting there for a long time and look bad. So look at the tube, and if you can generally see through the tube into the sheet underneath it, you're generally fine to send that patient home or follow up as an outpatient. So the etiology of gross hematuria, you probably remember all the different types of mnemonics. The one thing that, of course, I have bolded and underlined is bladder cancer. So gross hematuria, painless gross hematuria, is bladder cancer until proven otherwise. So if that patient has gross hematuria and they don't have any sort of identifiable cause, urinary tract infections, stone, they've been catheterized recently, that patient really needs a urologic workup. Not necessarily emergently, just sometime in the next few weeks. The management of gross hematuria, I want to point out a large bore catheter, 22 French or larger. If you have concerns about clots, you need to hand irrigate that catheter first. It's annoying, and I understand that because I usually do it all the time, but you've got to hand irrigate the catheter before you start any CVI. So you can, this is kind of my way to do this. I think everybody has access to slides afterwards, so feel free to go back and look at this. But the most important thing is to always have more in the bladder than you can physically pull out with one syringe worth. So I usually put 2 or 3 in the bladder before I am pulling anything out to make sure that you're not sucking the back wall of the bladder against the Foley catheter. It's painful, and it can induce more bleeding, unfortunately. So, and last resort would be us taking the patient to the OR for clot evacuation. So, microscopic hematuria, so that part at the bottom, 3 to 5 red blood cells per high-powered field, that is the definition of microscopic hematuria. So, we cannot diagnose microscopic hematuria on a DIP urinalysis alone. It has to be a true microscopic analysis. So it is 3 to 5 red blood cells, basically anything more than 3, on a properly collected sample in the absence of any other identifiable reason. So that's what we were talking about with urinary tract infections or kidney stones, or they've been catheterized recently. Any of those reasons, check a urinalysis a month and a half later. If there's still microscopic blood there, that's when that patient deserves the workup. And that workup includes 2, maybe 3 things. Number 1, the CT urogram. It would be awesome if they came to our office with the CT urogram, just because it kind of gets us down the road of working that patient up. That's a triple phase study. I think I'll talk about that in a second. We always have to do a cystoscopy in the office. That's almost always office-based. And then cytology plus minus. Cytology's kind of fallen out of favor, but it's not a bad idea, especially, it's easy to order. So these are the reasons why you would want to refer for hematuria. Remember, the CT urogram is a 3-phase study. Just if you'll say CT urogram on your order form, your radiology department will know what that means. And remember to make sure that you get a true microscopic analysis when you're checking that urine. So, again, last time, gross hematuria, painless gross hematuria is bladder cancer until proven otherwise. Even if they're on aspirin, even if they're on Eliquis or Xarelto or Plavix or Effient or all the other drugs that I absolutely despise, they all need their workup. It does not make them bleed, it just makes it easier for them to bleed. So they deserve that workup. As you can see there, 23%, a quarter of those patients with painless gross hematuria are going to have a GU malignancy on workup. So this is one of my overnight escapades in the, I don't know if that can show up very well, but anybody know what that is? Zipper? Who's done a zipper injury before? Yeah. Mineral oil is a huge one. Get mineral oil, and then I don't have any idea what this thing is, but it actually worked for me. And so I never saw the patient again. He was 37, not a kid, and I think he had a little too much to drink that night. Paraphimosis is one of the things that we would get called for in the middle of the night. One of the things actually that's fairly easy to take care of. As you can see, there's a lot of edema over here on the coronal sulcus and this foreskin. The edema is what hurts. It causes pressure and necrosis, and that's what actually hurts. So the obviously way to diagnose is just a physical examination. One of the biggest reasons why paraphimosis happens is us, doctors, nurses, putting catheters in and not reducing the foreskin back over the glands. So be sure, if you do a lot of nursing home work, just be sure to look at the catheter every day. And if they're uncircumcised, just make sure that the foreskin is over the glands. You can retract it every day and reduce it. It takes, 5 seconds, right? One of the ways that I describe how to do this is pushing the Slim Jim back into the wrapper. Everybody knows what a Slim Jim is. So I know it's really kind of weird, but if you are pushing it back in and pulling up that plastic, that's the action, so to speak, of doing it. Most important thing to do is just squeeze. Patient can do this, nurses can do this, a CNA can do this. Is just you want to squeeze from the tip all the way back towards the glands. Literally 4 to 5 minutes should be enough to reduce that inflammation and the edema for you to push the glands back in. That's all it really takes. You can also put the ice in the glove. You can look at that. You can use some Imla cream. And final thing would be to do a dorsal slit or poke the foreskin with a needle just to let some of that edema out. Phimosis, the alternative there, is where the foreskin cannot be retracted back. This is only an emergency if the patient can't urinate. It's certainly something that we need to address, but if the patient can't urinate or they're leaking all over the place, they've got sacral wounds, those are the types of things where phimosis becomes an issue. Generally speaking, poor hygiene, just poor foreskin. My treatment of choice for mild to moderate cases would be betamethasone cream, as you can see there. If they are concerned about a fungal infection as well, use Lotrazone cream with the clotrimazole in it. Use it 3 times a week, and Aquaphor is always helpful, alternatively, just to help that area heal up. This was during residency. I didn't take a picture with it, but a patient using substances, shall we say, hired a escort, I guess, shall we say, who wrapped hair around there. That's hair. Had no idea. So always, of course, be vigilant, watch for things, do a physical examination, most important thing. The ER did not know anything about this when they came through. So now we're going to do some plumbing, more upper tract stuff, hydronephrosis. Kidney stones are really the most common cause of hydronephrosis. All hydronephrosis needs to be at least followed, if not evaluated by urology. Hydronephrosis should not be there. So ultrasounds, renal ultrasounds are the best way for us to do that. Other causes, malignancy within the ureter, that's a ureteral mass versus external compression by generally gynecological malignancies, that sort of thing. You can get a UPJ obstruction, which is a very common cause of this as well. You can see here on the patient's right-hand side this significant hydronephrosis right here, and causing actually a delayed nephrogram here. That's what that looks like. Sometimes hydronephrosis is asymptomatic. Usually they have flank pain. They usually have kidney injury, elevated creatinine, decreased GFR. And again, asymptomatic hydro is really bad because that patient doesn't know that their kidney is failing them. When there's a stone or any sort of other obstruction with infection behind that, that's a quote-unquote septic stone. So you can see there on the patient's left, that stone in the ureter and that significant swelling beyond that, that's hydro. Now, on this x-ray or on this CT, we don't know that there's infection. I do because I actually saw this patient. And what is behind there is that. I don't know if that shows up really well, but if you can see, well, you can't see the sheet underneath that. That is all pus. And that's why septic stones are so dangerous. This will absolutely get me and most urologists out of bed in the middle of the night to come and put a stent in that patient. This is actually a patient I took care of. You can see their bag over there on the left. It's just nastiness. He went home a day later, which is crazy. He was getting wheeled out of the hospital. I was like, where are you going? And he said, I'm going home. I was like, okay. But he's doing much better now. But all they need is a stent at that point, and then we can take care of the stone down the road. So diagnosing hydro, stones, et cetera, CT is always the gold standard. You can use an ultrasound, especially to follow up. But before most any urologist would take a patient to the OR, we want to see a CT scan, know where the stone is, and kind of what we're going for. And you can see hydronephrosis, when is an emergency, if they have signs of sepsis, fever, tachycardia, septic shock for sure. If we're not available, IR can put a percutaneous nephrostomy tube in. I always put a Foley catheter afterwards just to maximally drain the system. So, one of the questions that we always get is, when do we call you about stones? We see a stone incidentally on an imaging study, and according to the AUA, you can watch these asymptomatic or even minimally or moderately symptomatic stones up to 1 centimeter. Believe it or not, it's 6 weeks. I don't think anyone would ever spend 6 weeks suffering with a stone, but if they are comfortable, it's certainly reasonable to wait. You can send them home with Flomax, antibiotics if they have signs of an infection. I want you to see Toradol there in all caps. We'll talk about that. Also, please send them home with a urine strainer if you have it. That way, if they collect it, we can analyze it. You can see the emergencies there. Pregnancy is one of those things you want to give us a call about. Intractable nausea, vomiting, pain, sepsis, solitary kidney, either congenital or if they had a renal mass and they had their kidney removed, that's certainly one of those things that we want to consider. Anybody not a fan of giving Flomax for stones, raise your hand. Who doesn't give Flomax for stones? Anybody? Good. This is the reason not to. There's a study out that said there was a 3% difference in Flomax group versus the non-Flomax or placebo group. That was out of the UK. Had 512 whopping patients in the study. I don't really believe that. So this is the reason why you should. meta-analysis with over almost 10,000 patients. And it showed higher expulsion rate, quicker time to expelling the stone, lower incidence of colic, and fewer incidents of subsequent interventions, which I think is important. So in my opinion, I recommend using it. It's low risk and high reward there. So, but please use Toradol. Toradol is absolutely the best medicine that we have for kidney stone pain. If you've ever had a kidney stone, most likely you've had Toradol. And the vast majority of my patients say the Toradol was the one that worked. They didn't like the way that the narcotics made them feel. We're also obviously trying to use less narcotics in general. So that comes in a nasal spray. And you can use that transiently in patients even if they have acute kidney injury. Additionally, if they've had a gastric bypass or some sort of weight loss surgery, it can be used. You may want to use it very judiciously, but it can be used with those patients. I would not obviously use it on patients with history of bleeding ulcers or other things like that. So, testicular torsion will also get me up in the middle of the night. That's a testicle, obviously, that on the right-hand side that has been torged. That's actually after it has been untwisted, and you can see what it looks like on physical presentation. These patients are significantly in pain. A lot of times you get them later because they're kids, maybe they're with their mom or someone they're embarrassed. So unfortunately, they come after that magical 6-hour window. The reason, of course, why the pain is present is because of infarction, because of necrosis, and arterial compromise, venous obstruction, not allowing that blood out. Number one thing is to make sure that you get a Doppler ultrasound immediately. My facility sometimes does not have your ultrasound coverage, believe it or not. And so if you suspect that, you need to call the ultrasonographer in, and you want to do that even before you give us a call. You can do it 1A, 1B, whatever, but make sure you get the ultrasound. Now, if there's no ultrasound available for whatever reason and it's a very convincing story, give us a call. Sometimes we have to take that patient to the OR anyway and explore the patient. Again, you have this 4 to 6 hour window here. After that, salvage drops precipitously in terms of percentage, but again, even at 6 hours, we have a 93% chance of saving that testicle. So just like the heart, just like brain tissue, time is testicle. All right, who wants to venture a guess as to what that is? Don't be shy. Anybody? Those are tongue bars and the dilators that went with them, and that is in a patient's urethra. I took that out at about 2 o'clock in the morning. I joke sometimes that I run the Foreign Body Center of Excellence around here. So very, very interesting gentleman who decided to do that. So scrotal abscess, diagnosed ultrasound CT. Generally speaking, scrotal abscesses almost always are superficial. They do not involve the testicle. I shamelessly put this in here, does not necessarily require urology to come and drain the scrotal abscess per the ER literature. You won't get into the testicle, I promise, if you want to drain this. These are easy to drain. You can isolate the testicle with one hand and just make a small incision. Once that patient's abscess is drained, that patient's going to feel better generally in about 5 minutes. It's the pain on the testicle that hurts. A lot of people ask, well, why don't you inject them with lidocaine? I said, because it's going to make things worse until I drain it. I mean, they're not going to feel anything better with lidocaine or anything like that going in before the scalpel goes in. So the key is to get them drained ASAP. That's Fournier's gangrene. Has anyone ever seen Fournier's? Everyone's smelled Fournier's, right? Worst smell in the history of the world. I talk about how we smell the room number. You're walking around the ER, you don't even have to know where you're going because you can smell it. It's that bad. This is, of course, neck fash. They have crepitus. They have necrosis. These patients generally have diabetes. They're vasculopaths. They have a history of perirectal, perianal infections. A lot of times it's because they're leaking urine and they're sitting in urine. They're sitting in their stool. It's always multi-factorial in terms of their bacterial cultures. E. coli is the most common. If you get a CT scan, you're going to see that. That's gas in the and that's a bad thing. Afterwards, this is unfortunately what has to happen sometimes, is they have to have significant debridement. You have to divert them urologically with urine as well as with stool. Sometimes you have to do thigh pouches and their tensor fasciolata, which is kind of a cool thing to do. We don't get to do it a lot, which is a good thing. Priapism, that's an erection lasting longer than 4 hours. You're getting pain from the ischemia. You're getting pain from necrosis. This is named after the Greek god of Priapus. Again, just a little bit of urologic humor there. You have to have a little bit of fun, right? So the causes of priapism, you can see, generally speaking, it's because of medicines, but it's not just the medicines alone. So erectile dysfunction medicines almost rarely causes medicine. It's the patients who's taking that, and they're taking something from the gas station and something they got on the internet, and et cetera, et cetera, et cetera. Also, substances, cocaine, marijuana, all these things will cause priapism, especially if they're taking medicines. Trazodone, remember that one, and other antipsychotics as well. Most important thing here, if they have non-ischemic priapism, they do not need to necessarily be drained or injected or treated or anything like that. So you need to get a penile blood gas. And the way you get a penile blood gas is the same as you get an arterial blood gas. You get the ABG kit, and you draw some blood from the corpora cavernosa. You only need to do one side, and you can see the different ABGs there that you'll get. It'll be acidic and very dark, purple, black, something like that. So you want to. This is just really for your on the off chance that we're not available. A lot of ER doctors are doing this for us now, which I appreciate, especially if I'm in the office, because this is going to be an hour and a half, 2 hours out of my time, and that means that I have to reschedule patients from the clinic and that sort of thing. Obviously, we'll do it if we need to, but it's actually not very difficult to do. And I say at the bottom, when in doubt, YouTube. It's actually very helpful. You want to make sure that you get your phenylephrine mixed at the right dose. 500 micrograms per ml is what I generally use. That's the highest. And I just don't really mess around with lower doses because you only have one shot. If not, you're going to take the patient to the operating room anyway. So you want to do a penile block. That left picture shows kind of where you put your needles there, some of the relative anatomy. Priapism, most important thing with this is that you want to counsel this patient and consent the patient for everything before you even touch them. There's a lot of obviously litigious kind of stuff out there. Once you get priapism, you are already down the road of having permanent and irreversible erectile dysfunction. And so you don't want to have somebody come back and say that you caused this, and you get that bruising around there. These are the causes you can imagine there. Anatomy, you can get an MRI if you want to, and you can kind of see, I can't see very well, right here and right there are the defects. But if they have a significant story, if their story checks out, you really don't need to get the MRI. MRI techs aren't going to come in the middle of the night to do that, almost always. Complications you can get, curvature, plaque formation, Peyronie's disease, By the way, Peyronie's disease does not have good treatment options, so the whole bentcarrot.com website that patients are asking you about and us about, it doesn't really work very well. We'll still talk to them about it, but they need, generally speaking, a surgical procedure. That's an aside. But they can get permanent and irreversible erectile dysfunction as well as curvature of their penis after a fracture. You want to get this done sooner than later in terms of treatment. So in generally speaking, if they come 24 to 36 hours after the event, there's really no benefit to taking them to the operating room. Anybody know what that is? Say it out loud. It's a fishing lure. That was in someone's bladder. He was an accountant, and he and his wife were having a nice little Friday morning, and they got it. They lost control of it, shall we say. So again, foreign body center of excellence. Bladder rupture, this is really bad. You can see the top picture right here is a extraperitoneal, that's an intraperitoneal. You can see the outline of bowel with the contrast. This is extraperitoneal, the flame sign right here. Generally speaking, extraperitoneal ruptures can be managed with just Foley catheter alone. There is some data now that intraperitoneal ruptures can actually be managed like that as well. The most common cause of this is actually us, again, urological surgery, gynecological surgery. Our colorectal guys don't, a lot of them have stents in before and they're not really near the bladder, but certainly something that's significant to the patient if it happens. You want to get a CT cystogram, that's how you diagnose it. You want to get a catheter in. Gross hematuria, obviously, if they have that, very reliable. You're also going to have difficulty in irrigating the catheter. Please do not run CBI in patients that you suspect have a bladder rupture, because all you're going to do is fill their peritoneal space up with a lot of fluid, and it's going to hurt. So again, management of these, extraperitoneal, conservative, intraperitoneal, take them to the OR versus observation, depending on how they're doing. BPH, one of the most common causes of, or most common reasons that someone will see us. This is an anatomic condition. I'm going to say that a couple times throughout the section here. So just consider, treating these patients for their anatomic condition, not just physiologic. We'll talk about that and what that means. These are the causes of this, or these are the symptoms: obstructive or more prostate issues, irritative or more bladder issues. This is BPH on a cystoscopy. That's what it looks like when we see a patient. You see those lobes, those are called kissing lobes. And so that's what we want to try and work up and treat. So what you want to do, you can get the AUA score online. It's free. It's also called the IPSS score. It's very helpful, very well validated questionnaire. You can assess the size. You can get a transrectal ultrasound. Your hospital ultrasound people are not going to do that because ours don't. Or you can get cross-sectional imaging and measure it. You want to get a post-void residual, which again, most places don't have unless it's the hospital setting. So management of this, first, of course, is medical management. Flomax is by far the most common. There's also silodosin, alfuzosin, doxazosin, terazosin, all the zosins. You can go up to 0.8 milligrams on the tamsulosin. I have finasteride and dutasteride in bold and underline here. There's a lot of emerging data. It's actually been around for a long time that these medicines cause a lot of irreversible side effects. So I am really trying to not use the finasterides, the 5-alpha reductase inhibitors that have significant sexual side effects that are potentially irreversible. Once they fail medicines, then we're talking about a surgical procedure. The TURP is still the gold standard. I do a lot of TURPs. We tell them about all the things that could go wrong, or the side effects, specifically retrograde ejaculation, some erectile dysfunction, but generally retrograde ejaculation. Incontinence is an issue, but if done properly, they should not be incontinent afterwards. Prostatic urethral lift, that's called urolift. You may have heard of that. And then I also want to point out aquablation. So aquablation, I have a little video. I don't know, can you click that and see if it plays? I think it's only like 45 seconds. If not, you can Google it later. Maybe not. All right, I guess in the absence, yeah, we'll just skip it. But aquablation is a relatively new way. Unfortunately, it's very expensive. The machine itself, it operates, it's actually a robot. It looks like a upside down windshield wiper that ablates tissue with just a high stream of water. So you're not using any heat. And actually has some really good data behind it. So be kind of looking out for that over time. Urolift is something that we've been using now for about 12 years in the United States. Think about those lobes that you saw in the picture being kind of moved to the side, almost like curtains. We kind of tack the curtains back is the way that we describe it to patients. It's durable. It's probably not as good as what we hoped it would be, and certainly not as good as TURP, which is still the gold standard, but is still a very good option to treat patients minimally invasively. So, I can't advance. I'm just getting that click. I can see it here, but there we go. Let's see. Perfect. All right, so now UroLift. We talked about that. And then, of course, treating BPH as a primary care physician is certainly something that you guys can do. Medicines certainly work, but once they fail medicines, or if they're not getting better, or they want to get off medicines, we like to think of this as really an anatomical condition. You saw that picture. That's what most of the prostates look like. So an anatomical condition deserves an anatomical solution, and you can get these patients off their meds with the right thing. So just as a reminder, ask questions. PSA screening, should you screen? Yes, absolutely. And if you have any questions, hopefully those will be answered here. One more picture here. Anybody know what that is? It's not a heart. It looks like a heart. That is a liposarcoma of the spermatic cord. My attending is there in the background. That was during residency. Very, very large mass, treated, generally speaking, with just surgery and then local recurrence with radiation. So I thought that was pretty cool. Everybody knows about PSA, what it is. We know why we do it. PSA, and prostate cancer rather, is second most common cause of cancer-related death in the United States. So this is a huge controversy. I'll spend a little bit of time on this. So it came out in 1994 in terms of the test. And of course, prostate cancer incidence shot up because now we were finding it early. In the late 90s, early 2000s, everybody got their prostate out because we didn't know that there were certain types of prostate cancer that we didn't actually need to treat. So around this same time, we were finding this out, and the government was finding this out. And the government wanted to save money. This is not a political statement in any way, but they wanted to save money, so the USPSTF issued this draft recommendation in 2011, which then became the law of the land in 2012, saying that in all age groups, in all patients with family history, with African American, African Americans have a higher risk of having prostate cancer. All race groups, none of them actually were supposed to get PSA screening, which we obviously believed was not the case. However, that came to fruition. They made that rule. They used data from the PLCO trial as well as the European trial. The PCLO trial, was later found to be contaminated. You can see that 80% of controls without baseline screening had PSA screening during the trial. So that pretty much says that that's not a very good trial, right? 90% of the controls reported at least one PSA test before or during the trial. Thus, the control arm actually had a higher screening rate than the screening arm, which diluted the benefit and thus showed that they were using diluted, poor data to come to their conclusion. That's the long and short of why the PCLO trial was pretty terrible. The European trial was found to have a 30% reduction in development of metastasis in the screening group after the data was followed for longer, because prostate cancer generally takes longer to grow and to metastasize and to cause trouble. But unfortunately, as you can see, PSA screenings in population fell by 50%. By the fall of 2013, a very large group, urology group, had a near 30% drop in a year, a 30% drop in the number of prostate biopsies. So if we're not screening, we're not biopsying. If we're not biopsying, we're not treating prostate cancer. Unfortunately, the rates of higher grade, higher stage distant metastasis prostate began to rise. They weren't being screened appropriately, and unfortunately now we are paying the price for that. We see patients come in who could have been found 5 years ago or 6 years ago. The USPSTF at the time had no oncologist, no medical oncologist, no urologist, or anyone who treated cancer on the panel that made that decision. And not only that, an entire generation, maybe some in here, were kind of taught that PSA screenings are bad. And I don't want to necessarily get into the controversy of that. Medicare was about to actually make that a negative reimbursement factor back in 2016, I believe. They did not do that. And so this is what I want to kind of tell you guys about, which is that over-detection is marked out because I don't believe that over-detection is a thing. Now, 90-year-old guy with coronary artery disease and stroke history, he doesn't need a PSA. So we can be smart about this, but at the same time, our patients who are 55 to 70 to 75 who are healthy, they need PSA. And so we don't want to concern ourselves with over-detection in that population. We want to concern ourselves with, over-treatment. And so our goal is to decrease men with prostate cancer that will actually hurt them over time. And there is cancer, again, that we should not treat. This is the low-grade Gleason 3+3 disease that now all urologists, virtually all urologists, are watching with active surveillance. So these are the current USPSTF guidelines. You can see them for your, I'm not going to read them there. These are the AUA guidelines, and this is what I follow. So 40 to 50 only offer screening for patients who are higher risk, those with who are African American race with significant family history. That's a brother or a dad, or have known germline mutations. Their brother had it or whatever. In the 40 to 50-year-old, you can consider screening with a baseline PSA. My family doctor does that. 50 to 69, those patients should be screened regularly. I say every 2 to 4 years. I think that's a very reasonable thing. After 70, then that becomes a discussion. And a lot of times that's where they're sent to us to have that discussion, which is certainly fine. I meet with a lot of guys who, after we talk about it, they say, I don't want PSA screening because I'm not sure if I would do anything about my prostate cancer even if I were to have it. And that's totally fine, but that's what needs to happen, is that shared decision making. These are the NCCN, National Comprehensive Cancer Network. These are their guidelines. They look virtually identical to the AUA. The AAFP does not recommend PSA screenings in anybody, basically. And again, as you can see, I respectfully disagree with that. Even the USPSTF disagrees with that. So this is who I screen, how I screen, generally speaking, 1 to 2 years, depending on the PSA velocity, et cetera. MRI and prostate cancer, this is very much here. We use MRIs all the time. We use PSAs all the time. but it's expensive, and a lot of times insurance companies won't pay for it unless they've had a negative biopsy before. So the other thing is, most importantly, at least 9%, in some studies up to 15% of clinically significant prostate cancers. That's prostate cancers that would kill somebody if left alone long enough, are missed on MRI, which is unacceptably high. So unfortunately, the biopsy is still going to be a mainstay of workup for this, but the MRI is a nice adjunct. So we don't obviously do prophylactic prostatectomies like some patients, are getting mastectomies done. There's nothing really to prevent prostate cancer. I tend to believe that there is something to be said for the Mediterranean diet. I think that has some good data to it, but we can't take vitamins to make cancer not show up or anything like that. This was all studied. One other thing, just as a reminder, if you're checking your PSAs regularly, make sure that you tell these guys not to do these activities about 5 to 7 days ahead of time, because those all increase your PSA, and so then we are working up kind of a spuriously high number. And if they have, just recheck it in a month, something like that. That's all you have to do. When in doubt, just ask. Always send them to a specialist to have that discussion with them. We'd be glad to have that with them. Incontinence, I've got about 5 minutes left, so I'm going to kind of skip through this a little bit. We all kind of know about incontinence, but the thing I want to tell you about mostly is urge incontinence. This is the thing that I find most patients tell me that they have the most worry about, is urge incontinence, not being able to get to the bathroom on time. And that can be because of bladder volume, that can be because of detrusor instability, true overactive bladder. This medicine right here, these medicines rather, are a godsend. I don't know, has anyone used the Gemtezas, the Mirabetrix? They're awesome. I don't find a whole lot of patients with side effects from them. They don't have the side effects like dry mouth, dry eyes, constipation like the old medicines, oxybutynin and all those. So these, I would highly encourage you to use these medicines. They are great. And if that's not working, or if you don't want to do that, you can send to us, and then we can also discuss, Botox for the bladder or sacral neuromodulation. Renal cyst, simple renal cyst. If they say simple, you can generally just forget about it. Don't even have to send them to us. If they're anything like class 2 or certainly 2F or higher, as you can see on this score, if you see that, that's what they need to come to see and follow a urologist. So we have a few minutes to talk about testosterone replacement deficiency and therapy. If done right, TRT is beneficial. If it's not, it's unsafe. I put this in here because patients are actually coming to us and asking us to manage testosterone deficiency. And I don't want to speak pejoratively about men's health clinics or those types of things, but there are certainly a lot of clinics that's all they do. So if you're a testosterone clinic, then you want people to come back for their testosterone. So I want to give you a little bit of information and kind of hopefully empower you to do some of this, because if they get it done right, then they won't be going to these other clinics where they're not doing it right. They're not checking their labs, et cetera. And so this is the definition. That doesn't really show up. I'm very sorry about that. Less specific, as you can't see on the right, are things like decreased energy, depressed mood, decreased concentration, increased fat mass. Those are what a lot of people consider low testosterone to be associated with, and there's 10 things right now I could come off at the top of my head that cause all those things. So generally speaking, yes, they could be testosterone deficient, but they could also not be eating right, they couldn't be exercising, they're actually depressed and it's not testosterone, they're not sleeping well, all the things that cause this. So evaluation, most important. They have to have 2 separate levels drawn. Now, there's no agreed upon rule that has to be separated out by a week or 2. I generally separate out by a couple weeks just to get 2 different levels, but they also need to be early morning draws, so 8 a.m. or earlier. Some people say 10, I just say 8 because very rarely are they going to be there right at 8 anyway. You can consider a free testosterone level if their levels are borderline. If their total testosterone is low, get an LH level, and I just get this anyway. I get free total, I get LH. If they have any concern of gynecomastia or anything, I'll check a prolactin, get an estradiol as well if they have that. These are absolute contraindications to it. You want to watch their hematocrit over 50%. Heart failure is bad. Obstructive sleep apnea, you don't want to give it to those patients. And again, prostate cancer if it's untreated. Just know that if you treat the prostate cancer, generally speaking, within 3 to 6 months, as long as you're following their PSA or a urologist is, you can actually treat them again with testosterone if they were adequately treated. Relative contraindications, again, elevated PSA requires workup. If they desire fertility, then you probably don't want to give them replacement. There are some other options out there. These are the formulations. I use mostly shots. The pellets are kind of cool. That gives an injection and generally speaking 3 to 4 months of steady testosterone. And then these are the side effects: testicular atrophy, infertility, sometimes irreversible, hematocrit going up high. You can still give that patient testosterone, but they do have to get their blood drawn and have therapeutic blood draws in order to get that down. So monitoring, you want to do, I see these patients about every 6 months. First time I see them is about 3 months, and then every 6 months. You do want to check a lipid profile regularly. And then your goal, again, is number 1, symptom improvement, but around 400 to 600. The range is 300 to 700. That's generally the accepted range. So these patients who want 1,200, 1,400, I don't participate with that. They can find that if they want to, but I'm just not interested in helping people, super therapeutic. Consider younger men on these other alternatives: clomiphene, HCG, and endocrinology. I send people to endocrinology a good bit. So I'm only 48 seconds late. So this is when to refer to urology. I hate that I couldn't get through everything, but sorry, not those questions. Any questions? And that's my cute dog. Yes, sir.
Yes, Toradol usage in kidney stones.
Uh-huh.
It's supposed to be limited to 5 days normally. What happens if you can't see a urologist and they're still having pain after months? What would you?
After you said months?
Yeah.
Oh man.
I've got a friend of mine who had
that,
basically.
And so at that case, I mean, you can't use Toradol that long.
Right. Exactly.
Tramadol would be a good option, or you can, go to a narcotic, low dose Percocet 5-325. Yeah, I mean, I don't want to, but I value trying to get those stone patients in because people feel really bad with a kidney stone. I've never had one personally, but obviously I take care of a lot of them. So if it's months though, yeah, you gotta get them either find a different urologist, or you have to give them Tramadol, Percocet. Yeah. What other questions do you have? I know we went through a lot. Right up here.
I looked at clomiphene on Up to Date once, and it seemed a little controversial. Can you kind of speak to that controversy?
It is. I put that actually in there as just it's out there. I don't prescribe clomiphene or Clomid for guys. If they fail, so to speak, or if they don't get the results that we're looking for with traditional TRT, then I'm generally going to give them an endocrinology referral. Part of that is because I'm a solo urologist right now. It's very hard to find urologists, and so I don't have the bandwidth, so to speak, to manage that type of thing when I've got other people who really need care a lot sooner: stones, blood, cancer, other things that I take care of. It is relatively controversial, as is HCG in guys, but it is a valid way to do it. It is off-label use, but it is a valid way to treat patients' testosterone deficiency and it doesn't just replace it, of course, with the HPA axis and all. So yeah.
Any other questions?
All right. If you have any questions, Amy has my information. I didn't put my email address up there or anything like that, but you can always email or call. And I hope everybody has a great rest of the conference. Thank you.
Before I introduce our next speaker, as a reminder, we do have lunch that will be available after this last lecture. So if your families are here on site, invite them down for lunch to be able to view all of those posters as well. Dr. Ryan Alexander is an addiction medicine specialist and is currently the medical director for substance use services at McNabb Center in Knoxville, Tennessee, and an assistant professor at the University of Tennessee Graduate School of Medicine. He completed medical school at LMU-DCOM in 2017, his residency in preventative medicine and public health at Griffin Hospital, Yale School of Medicine, and a fellowship in addiction medicine at Yale University, Yale School of Medicine, and a fellowship in addiction medicine at Yale University School of Medicine. In addition, he completed a master's of public health at Yale School of Public Health. In addition to treating patients, Dr. Alexander conducts clinical research and has published multiple articles related to addiction medicine. He also regularly teaches medical students, residents, and other medical professionals about treating substance use disorders, reducing community stigma toward individuals with substance use disorders, and expanding access to medication treatments. Please help me welcome Dr. Alexander.
All right, hello. Almost made it to lunch, you're doing great. We're gonna finish up strong. Good, I can work this. So no disclosures, we'll just jump right in. Here's my objectives to review those. No disclosures, we'll just jump right in. Here's my objectives to review those. I'll tell you right now, I'm gonna focus on an overlying objective that's not listed there, which is I'll lead you through understanding and really gaining a new perspective on addiction treatment. And hopefully, you know, what we'll accomplish together is that you'll addiction is a disease. Not just hear me tell it, or maybe you've heard it before, but through a series of discussions together, hopefully you'll believe that and be able to carry it forward. Maybe many of you will be able to put some of the treatment recommendations, which we'll discuss at the end, in your clinical practice. But if not, at least you'll have a more holistic, humanistic perspective on addiction, the etiology, and then the treatment philosophy. So really, this is kind of a rhetorical question, but what is addiction? Just think about it in your mind. I ask medical students, residents this all the time, just to philosophize about it for a minute. Just think, what's the first thing that comes to mind? Is it just bad choice, gets out of hand, a learned behavior, you grew up in the wrong part of town, bad luck? Does it qualify as a disease? These are all questions that I'm asking you. I ask my all the time, better understanding. But it's also discussed in the addiction treatment community and commonly discussed in the media, literature. So, even amongst addiction specialists, there is whether it qualifies as a disease or not. There are books you can buy, national bestsellers that say it's not, national bestsellers that say it is. And so really, I just want to walk with you through gaining an understanding so you can decide, and I think you'll decide with me that addiction is a disease. But to really answer that question, we need to determine what a disease is. And I know this sounds like a silly question at a medical conference, but I ask rooms of medical students this all the time, and it's really hard for people, even people who treat diseases on a daily basis, to define what a disease is. And luckily, we can look it up in the dictionary. But the important thing to note here is that it's dysfunction of an organ or system, body system, with consistent signs and symptoms. And that's the thing that makes something a disease. People often say, well, is a gunshot a disease? Well, no, because that's a traumatic event. It's different for everyone. So really, having the consistent signs and symptoms is what makes it a disease, as well as causing organ dysfunction. We like to think, though, that diseases are simple, all right? There are very few simple Mendelian single gene defects that cause diseases. Most diseases are more like this. They involve many different aspects interplaying at the same time. And this is kind of a thought experiment to help you understand addiction a little bit in the context of other diseases that we treat on a regular basis. This is just causes of death in the country. A little bit older data, it's 2022, I believe. As you may know, it's difficult to get updated data on government websites right now. But these are the leading causes of death. They haven't changed too much in the last couple of years, but just take a look at them. And I'm making an assumption that a lot of people don't automatically consider addiction a disease because it starts as a choice. That's most people's thought process behind that. Well, if it's a choice to use a substance the first time, you could just choose not to make that choice, and you would never develop the disorder or disease. But what you'll notice here is what are the leading risk factors for all of these, or many of these leading causes of death. And what you'll notice is the ones listed in red, which is almost all of them, with a red star, are mostly lifestyle choices that are the primary risk factor for these diseases. So we all treat diseases every day that start with a choice. Is a choice to smoke tobacco, right? That is a substance use disorder. That's an addiction just like heroin. So someone with COPD, you are treating a substance use disorder, but you're also treating a lung disease, but it started with a choice. So the same thing carries forward. And other diseases, diabetes. Type 2 diabetes is 95% of diabetes in this country. And how do you get type 2 diabetes? It's diet. That's a choice. But do not hear me wrong. I am not saying you blame the person for making a bad choice. And that is because different people have different access to choices. There's choice differential. People growing up in different neighborhoods have different access to choices. I have more choice availability for my diet than someone else. I have a vehicle. I can drive to the grocery store. If I don't live near one, I can get there. I make a high income. I can afford the Whole Foods. I can afford meals that are nutritious and delicious mailed to my doorstep. I can also choose to eat at Dunkin' Donuts. So if I have all the choices available to me and I consistently make the Dunkin' choice, well, that's on me. But if someone else living in a neighborhood with no income, no car, they live, so they have to be able to walk somewhere to gain access to their food. And there's 9 fast food restaurants on the corner of where I work. And the nearest grocery store is 5 miles away. So if you live in the neighborhood around where I work and you don't have a vehicle, you have 9 options of where you want to get food at an affordable price, none of which are healthy. So amongst your menu of options, none are good. So you can't blame someone for making an unhealthy choice when that's all the options they have. Okay. And this is just a depiction of the prevalence of type 2 diabetes in this country. I don't think we think of this enough as a man-made disease. But before 1950, type 2 diabetes hardly existed. And so how do you shift an entire population from less than 1% of people with a disease to 15%? That's a 1,500% increase in one lifetime. And it's not from individual choice. It's the system in place that is obesogenic. It's a system in place that means easy, accessible foods are the cheapest, least nutritious. So is addiction a disease? It's a choice what you eat, right? But the entire population of the United States did not choose to develop type 2 diabetes. It is because of these systematic environmental things that contribute to your risk of developing a disease. So really, addiction fits into this biopsychosocial model of having social determinants, environmental risk factors that contribute, and then your protective factors, your ability to work against the environmental pressures that are protective. And addiction really fits into that model. And so the definition of addiction from the American Society of Addiction Medicine is that it's a treatable chronic medical disease. And I think that's important because that means that there are, well, A, that it's treatable, but B, it sort of destigmatizes addiction as away from the historical perspective of it being a bad behavior or personal choice and more a medical condition that we can treat. And why should you care? I think all of you treat substance use disorders, whether you know it or not, whether you mean to or not, and expanding to treat the most deadly ones will benefit your community, benefit your families. Everyone's been affected by addiction personally, whether it's yourself, family member, coworker. It's the leading cause of death of people under the age of 45 in this country. You cannot look at that and say, I don't treat addiction. Somebody else can deal with that. It is a primary care problem. It is one of the biggest problems in our country, especially the East Tennessee community. If you're anywhere near this region, this is the epicenter of opiate overdose deaths. But aside from deaths, which should obviously be, avoiding deaths should be our number one concern, it is all the downstream effects of addiction that drive me to treat it, right? Incarceration. 80% of people in the Knox County Jail right now, I'm in Knoxville, are there on drug-related charges. Foster care is overpopulated right now. The number one reason of child removal from parent custody is parental drug use. It's obviously a leading cause of unemployment. All these social ills that could really affect your community, our community, and can really be improved with good evidence-based treatment. And this just shows a simple diagram of kind of the downstream effects that can be avoided with treatment. We can stop a lot of these things by treating substance use aggressively and treating it early. And even as we speak, even though opioid overdose deaths have been the leading cause of death of young people in this country for a decade, it is still massively undertreated. So how we treat addiction is really important. There are evidence-based treatments, and then there are bias-based treatments, right? I want you to be sober, and so abstinence is the only way. I want you to do this. I believe in that. These things are based in stigma, and they're not helpful for our community. What we can look at is saying, hey, what evidence-based treatments work? We need to save lives today, and be aggressive in treating addiction. So just like anything, if you want to, treat a rare infection and you're not an expert in it, you're going to look at the literature. You're going to look at what the best outcomes are based on studies, based on trials, things like that. We can do the same for treating addiction. There's a mountain of evidence that opioid use disorder is best treated with medications. And it's the same approach we take with other diseases. And that's why I want you to really work through the thought process of understanding that it's a disease just like type 2 diabetes. But when someone comes in the office with type 2 diabetes and you start metformin right away, why are you doing that? You're also talking about nutrition. You're also talking about physical activity, but the medication works now. It protects the body from the negative effects of ongoing hyperglycemia. We want to stop the kidney damage. We want to prevent blindness. We want to prevent people from losing limbs. So we can do that now with a medicine and work on the lifestyle changes, which are going to be slower. The same approach is very effective for addiction. Opioid use disorder and alcohol use disorder are the ones we'll talk about here, just because those are two of the most common and they have good treatment options and they're the most dangerous. So, medication first approach is what the evidence has shown to be most effective, because someone who is debilitated by cravings, debilitated by their substance use, they're not going to engage in therapy. They're not going to show up to their medical appointments. They're not going to go get a job. You need to stabilize that, remove the cravings, allow their frontal cortex to re-engage, give their brain space to function again. And medications can do that today. The therapy, the psychosocial interventions that need to take place along with that will take much longer. And it's almost a cliche saying now in addiction treatment, but you can't save somebody who's dead. Nobody who's overdosed and died is going to go get a job. It's too late at that point. So there are medications for opioid use disorder and there are medications for alcohol use disorder. We'll talk about them both sequentially, but it's really important to know that there are two phases. Well, that they're effective. You can see how effective they are. But there are two phases of treatment. The acute withdrawal management, but then you want to prevent a recurrence, okay? So we'll talk about that in detail going forward, but just know that it's always a two-step procedure. So we talked about how diabetes is the same approach. Like, we need to stabilize the system now and work on preventing additional detriment, in the future by working on behavior changes, which will take longer. All right, the second phase is the one that people forget all the time. So just keep that in mind. So for opioid use disorder, there's opioid withdrawal, which is the painful discomfort that is relatively challenging to get through on your own. Well, I have an inpatient medically managed withdrawal or detox unit where we manage this mostly, but we use things like Suboxone. You can use things like methadone to taper and reduce the withdrawal symptoms now. But then relapse prevention is where things can get controversial. I tend to just avoid controversy by relying on evidence and saying whatever the evidence supports is what I support. It's not what my personal belief is. I want to, bank on the statistics of you have the greatest option for success, greatest opportunity for success with option A. If that doesn't work, we can go to option B. And opioid agonist treatments have the best outcomes. So for withdrawal management, there's a full agonist of methadone and a partial agonist of buprenorphine naloxone, which is Suboxone. So if methadone is just not very common in this region, so we discuss Suboxone more, and we use that in our clinic. Most of the community where I work uses Suboxone entirely. If anyone has questions about methadone, I know it's pretty uncommon, but just feel free to shout out. But there are 3 FDA-approved medications for opioid use disorder, and this is the step 2. This is where the rubber meets the road. I always tell people detox is not treatment. If someone goes to detox because they've become dependent on an opioid, and you taper them off for 5, 6, 7 days, however long, and send them back out into the community, they have a 96% relapse rate in the first 30 days. You're sending someone who's just had a heart attack, essentially, out of the hospital without medicine, without treatment. What do you expect? So that is why, statins and aspirin and things are mandated after a heart attack. Why? To prevent a recurrence. But the standard treatment, this is not the standard of care. The most common treatment that people with a substance use disorder get is detox alone. We'll fix you up, we'll clean you out, and send you home. That is not evidence-based. That is asking for a relapse because you're not sending them out with any tool to prevent a recurrence. So these are the 3 medicines the FDA has approved to prevent return to use. Methadone is an option. Suboxone, like we just discussed, is buprenorphine with naloxone. That's an option. And Vivitrol is an option. So when you have 3 options, how do you choose? Let's look at the evidence. And the evidence suggests that methadone, it's the oldest medicine, is very effective. Reduces overdose deaths by 80%, reduces relapse by a similar amount. It decreases over time, but by a similar amount for the first 3 months. Now, methadone is controversial because it is the closest thing we have in this country of trading one for another. It's not trading one for another because methadone helps you function. And the definition of a substance use disorder is dependence and withdrawal along with dysfunction. If you're dependent on a medicine, think of something non-controversial, like a blood pressure medicine. You have to take it every day. If one day you don't take your blood pressure medicine, your blood pressure shoots up, you get flushing, a headache, chest pain maybe, that is because you are dependent on that medicine for your blood pressure to remain normal. That does not mean you are addicted. I know this is a simple sort of concept. Hopefully it's simple for you, but many people don't distinguish between dependence and addiction. They think if you need something every day, you're addicted to it. Well, no, that's not true if it's helping you function. If you need something every day and it's ruining your life, that's an addiction. So methadone, people become dependent on, but they're seen at a clinic every day, and it's so long-acting that it's stabilizing. And that's the key. That's why people do better on methadone than continuing to use heroin or fentanyl. It's because those things are so short-acting, you're always chasing your tail. You have to go into the back alleys to buy it. You don't know what you're buying. You might use the same thing from the same person today, and the same thing tomorrow could kill you. It's inconsistent, it's unknown, it's dangerous. So you switch someone to methadone, their life stabilizes. They're not chasing their tail all day. They are cognizant, their cravings are controlled, and they can return to function. So the key about that is not only does it save lives dramatically, if there was a medicine that reduced heart attack deaths by 80%, everyone would be on it. This reduces overdose deaths by 80%. It's a miraculous medicine. But it's dangerous. It's a double-edged sword. It's a full opioid. You can take more than is prescribed. It can cause sedation. It can cause side effects. But it's been around for 60 years. It was the gold standard. But not only does it reduce deaths, it improves functioning. The data has shown for decades that more people with methadone versus not are employed, have custody of their kids, are not incarcerated. So those are the major improvements in the community that I mentioned. Then Suboxone came around, and it's a partial opioid. And so you think a partial opioid for someone who's dependent on a full opioid, like heroin or heroin or fentanyl, a partial may be less effective. But what the data showed is that it is just as effective, but infinitely safer. So methadone, if you take too much, you can overdose and die, just like oxycodone or heroin. Suboxone has a ceiling effect. You take twice as much prescribed, it feels the same as a normal high dose of Suboxone. You take 100 times more than is prescribed, it feels the same as a normal high dose of Suboxone. So it comes with misuse deterrence, injection deterrence, so it's much safer and generally easier to take. Also in communities, methadone, you have to go every day to get dosed. Suboxone, you can get a prescription filled at your pharmacy just like any other medicine. So it's much less associated with it. You don't have to go wait in line and get your methadone dose every morning. You can fill your prescription at the pharmacy and go home and go to work. So I think the key here is that we'll talk about the questions and concerns with these medicines further down, but that the lethal dose is impossible to consume. Now that is with one caveat. If you mix Suboxone with alcohol, Suboxone with benzos, Suboxone with other opioids, the combination can be fatal, absolutely. But Suboxone by itself, the molecule, it is impossible to overdose on by itself. And then Vivitrol came out most recently, and this became everyone's favorite because it ensures complete abstinence. And particularly in this region of the country, it is mandated by many courts, by many communities, by many grant-funded agencies. You're on Vivitrol or nothing. The problem is you have to be sober from opiates for 10 days before you can even start Vivitrol. And just like we said, if you detox and leave back into the community where you came from, where you developed an opioid use disorder, the chance of relapse is 96% early. So has a very high barrier to induction or initiation. If you recommend Vivitrol for someone, you say, come back in 10 days, very few people ever show up for their first injection. And then if they do show up for a first injection, very few show up for the second injection. So what the data has shown over time is that there's such little engagement with Vivitrol. It doesn't take away cravings as much. It's not an opiate. It just prevents use. And it takes away your tolerance so that if after one injection you decide, I don't like how I felt with that, I'm not going to get another one, then you're untreated. And if you relapse one time, you're more likely to die. And so the manufacturer has actually stopped marketing it for opioid use disorder entirely. It's still FDA approved at the moment. But the data, this is when you look at the data and you say, if your family member, if your mom, if your brother had opioid use disorder, which one would you want? And for me, the Goldilocks is in the middle, the most effective and the safest. So for alcohol use disorder, this is the one that gets me with that step 2. This is the one where the standard care in the community is detox and go home. And that is neglecting the evidence that we have for medications that can prevent relapse. Alcohol use disorder is one of the most common co-occurring conditions for hospitalized patients. There's data showing that up to 40% of inpatients in any hospital, any given day, qualify for alcohol use disorder. It contributes to many. So these, this the same approach with withdrawal management and then the second step of relapse prevention. And similar to opioid use disorder, there are 3 FDA-approved medicines. Disulfiram is antabuse, you may have heard of. That makes someone horribly ill if they drink. That is a deterrent. Naltrexone is a mu-opioid antagonist and is probably the gold standard treatment. If I could give anyone advice in here, it's if you have someone with alcohol use disorder, it is naltrexone, PO, or once a month injectable Vivitrol, until proven otherwise. That is the easiest, most effective treatment. And then there's acamprosate. It is equally effective, but it's a 3-time-a-day, 2 horse pills 3 times a day medicine, so the compliance is very low. But naltrexone is a once-a-day pill or a once-a-month injection. There is risk of use in people with decompensated liver disease, decompensated cirrhosis. That is not true for early, mild, moderate cirrhosis. Only decompensated cirrhosis. So much so that it is not even recommended or necessary to check liver function in someone who appears to not be decompensated cirrhosis. It is more important that you prevent them from returning to heavy drinking because we know heavy alcohol use is liver toxic. So this is the menu of options for alcohol relapse prevention after the acute detox with benzodiazepines as the gold standard. Similar to what I mentioned earlier, after a heart attack, if someone goes to the hospital after an MI, they're on no medicines. They're from East Tennessee where, many people are just uninsured, don't see a doctor, haven't seen someone in 20 years. They show up to the hospital, chest pains. They're having an acute STEMI. What are the odds they leave the hospital with no medicine? They came in on no medicine. What are the odds they leave with no daily medicine? 0. If you're a provider and you send someone out after a heart attack with no prevention of a future heart attack, no treatment of their underlying cardiovascular disease, you will be sued. It's the standard to send people out after alcohol withdrawal with no treatment. So one may say, well, that's because we know statins are effective. We know aspirin's effective. Naltrexone, acamprosate, whatever you're talking about, it's probably not very good. The number needed to treat is the epidemiologic measure for how effective a medication is on a population level at preventing an outcome. So it's the number of people who need to be treated with a medicine to prevent one outcome. So the ideal number needed to treat is what? Somebody shout it out. 1, yes. So if you treat one person, they benefit. As an aside, Suboxone's number needed to treat to prevent death, estimated to be 2. It's the lowest I've ever seen of any medicine. But naltrexone and acamprosate, the number needed to treat is 14. One of the lowest I've ever seen. The number needed to treat for a statin to prevent a heart attack, about 150. So the fact that we let people leave the hospital after alcohol withdrawal with no treatment is egregious. So here's your options I recommend. Once again, the Goldilocks is in the middle. The only contraindications to naltrexone, like I said, are decompensated liver cirrhosis or concurrent opioid use, chronic pain, or someone on Suboxone maintenance for an opioid use disorder who then down the road develops an alcohol use disorder. You can't use it because they counteract each other. And if anybody can describe how blocking your mu opioid receptor treats alcohol use disorder, I'll give you a gold star afterwards. Let me know how it works. But we won't go into that now. So here is what I wanted to discuss with you all. So hopefully, you see how addiction can fit into the same etiology, the same pathways of disease, of the other common things we treat, like COPD, like diabetes, like cardiovascular disease, that you see the underlying risk factors for those things, many of which are smoking, which is a substance use disorder. You all are already treating substance use disorders. Now add opioid use disorder to your armamentarium. So these are the common questions that I get from people. First off, historically, many people were not allowed to prescribe Suboxone, so people never thought about it. They're like, well, I can't do that, somebody else is doing it. That is not true anymore. Can you prescribe Suboxone? 100%. If you have a DEA license, you can and should. In fact, I like to show this letter that I got from the DEA, and if you have a DEA license, or you did in 2022, you got this letter. Many people didn't read it, but I've never seen the DEA ask people to prescribe more of a controlled substance. But that is, in essence, what this letter says is, please prescribe more Suboxone. It is a life-saving medicine. The DEA removed any restrictions for it in hopes that people would prescribe more of it. When they removed the restrictions in 2022, they expected an uptick of Suboxone prescribing. They did not see that. So this letter said, please, you have no restrictions anymore, prescribe more of it because we have an opioid epidemic. And this is the gold standard treatment. The second question I get is buprenorphine or is Suboxone safe? And absolutely, there are very few instances where it can be problematic. First of all, I mentioned that the lethal dose is impossible to consume. 40,000 milligrams. It's because it has a ceiling effect. And I'll show you a brief image diagram of how that works but you can look at that on your own if you're interested. But in essence, it's very safe. The biggest risk factor you may have heard of, the biggest risk of giving someone Suboxone is precipitated withdrawal. And that is just when you give it too early and you cause someone to go into withdrawal temporarily. That can be very bad. If someone's sick already and then you make them more sick and they leave the hospital and go use again to try and feel better and overdose and die, well, that is a terrible consequence. But inducing a little bit of worsened withdrawal is the worst thing you can do. And this is a diagram of sort of how the ceiling effect works. And you can see on the left that if these are mu-opioid receptors, the orange ball is an opioid, it fills the receptor and turns on the receptor 100%, essentially. It's like a light switch, it's all the way on. Well, if you find every opioid receptor in your brain and you turn the light switch on, that's a total activation of 100%. But Suboxone on the right side is the green triangle, and it turns each light switch on 50%. So even if you activated every opioid receptor in your brain, the total activation would be 50%. So that's as high as you can go, even if you took 1,000 tablets. So these are the explanations for the reasons why Suboxone is safe that many people don't know, have never heard. In addition, Suboxone has a higher affinity for the mu-opioid receptor than any other opioid, which means if you have Suboxone in your system and then you take a full opioid, it can't displace the Suboxone. So it's actually protective while it's in someone's system. And the vice versa, so it's like a strong magnet. If you have a weak magnet bound to the receptor and you add a strong magnet, the strong magnet is going to take over the receptor. And so that is the explanation of precipitated withdrawal. If someone has a full agonist filling the receptors, you add Suboxone, it will displace it, taking that light switch from all the way on to halfway on. And it makes people feel bad because it happens suddenly. And this is a diagram of that. So if the maximum activation that someone can achieve with buprenorphine is 50%, then that dotted line is that maximum effect from Suboxone. Well, if you've been using heroin or fentanyl, you're used to a very high saturation of your mu-opioid receptors. And so if you give it before someone is in significant withdrawal, it will put them down to that 50% threshold. Now, if you meet someone who's 2-3 days since their last use, you give them Suboxone, it'll make them feel better. So it's all about timing. And to avoid precipitated withdrawal, there's a very simple mechanism, and that is just easing in. And this, if anybody has the opportunity to save someone's life by prescribing them Suboxone, this is a very simple way to avoid precipitated withdrawal. Just tell them to take a tiny piece of Suboxone every hour for 8 hours. And it's sort of like wading into the ocean versus jumping in. This is another common question, and I'll just tell you, it makes some people uncomfortable to say you might need a medicine for a very long time. But I look at it just like diabetes. You know how many people, first of all, type 2 diabetes is 100% preventable, 100% reversible as long as it's early. Do you know how many people who start medication treatment for type 2 diabetes ever come off the medicine? Ever? Any percentage out there? 50%? 2, that's optimistic. No. Yeah, it's about 10% is the estimate. 90% of people who ever start type 2 diabetes medication treatment just stay on it forever. I don't know what that says about people's ability to make behavior changes, but whatever you interpret that as, it applies to addiction as well. So I don't know why we feel differently about substance use than we do about other things, but we expect people to, who are dependent on opioids to stop using and be good to go after 30 days. So they used to say after 30 days of Suboxone or methadone, you should taper down. Well, they showed that to be dismal failure. Everyone relapsed. So they said, oh, okay, 3 months should be the recommendation. The same thing, 6 months. So now the current recommendation from many of the national organizations for addiction treatment say minimum. They used to say maximum, then taper. Now they say a minimum of 1 year of treatment, medication treatment. Then it's obviously a patient discussion to be had in the future. But I always tell people, as long as you are at risk of relapsing, fentanyl can be deadly today, or you end up in jail, or whatever other terrible consequence. So as long as you're at risk of relapsing, which can be catastrophic, taking a daily medicine is a pretty easy way. And I look at people who are at risk of relapsing if they're in the community where they develop their substance use disorder, if they are still unemployed or employed in a low-income job where they don't make enough to pay rent, or they're not housed, or they don't have transportation. These are all things that increase someone's risk of relapse. So if all of those things are improved and their life is improved and their behavior changes have taken place, they do not need to maintain on the medicine. That is categorically true. But the chances or the frequency that occurs is pretty low. So in an ideal world, yes, taper after 30 days. In a real world, it could be months, years. So these are next 2 or 3 questions that I'm asking and answering myself are based in stigma. I don't like these questions, okay? But these are questions people ask me all the time. So first, isn't taking Suboxone just trading one for another? Well, it's like trading a dollar bill for a $100 bill. So yes, sure. No, you're trading dysfunction for function, okay? If you tell me that taking Suboxone is the same as taking fentanyl every day, I don't trust you. You can see the categorical improvement, the difference. Like we said, you're going into neighborhoods that you shouldn't be in. You're buying things that you don't know what you're buying. You're taking things that you don't know what you're taking, versus stability, consistency, and safety. Okay, that is if that's a trade one for another, it's a big trade up. Do patients get intoxicated on Suboxone? If you have a tolerance to opiates, Suboxone is nothing, okay? It does not get you high, does not make you intoxicated. If you have never taken an opioid in your life and a Percocet 5 would make you fall asleep, then yes, Suboxone will make you intoxicated. That is why Suboxone should not be used in people with opioid use disorder. So I don't like this question because it's assuming that I'm giving this or I'm prescribing this to someone who doesn't need it, and that's not true. So people who need this medicine, it does not make you intoxicated. So what about diversion? Well, this should obviously be closely monitored, but in this community, it's challenging because I don't know how many of you work in Tennessee, but in particular, people with severe substance use disorder are disproportionately low income, disproportionately socioeconomically challenged. And Medicaid does not cover anybody in Tennessee unless you're pregnant. So many of my patients are uninsured, have no income, can't afford treatment. So if they can't afford to pay the $100 to see a doctor and $100 to fill their prescription, but they can afford $5 from their buddy to buy Suboxone today, or $10 today, every day, and they're buying Suboxone to prevent from using fentanyl, that's your own judgment on whether that's bad or okay. But the fact that Suboxone has a street value is more of a statement about lack of access to medications through a legitimate means, more than it is about people misusing Suboxone. Like I said, if you're using fentanyl, Suboxone won't make you feel any different. It'll just keep you from getting sick. And that's what most patients tell me. They'll say, oh, I bought a Suboxone because I couldn't afford fentanyl that day and I was sick. Well, treating opioid withdrawal is the FDA-approved indication for that medicine. So I say it's like, if I can't afford albuterol, my 6-year-old son has severe asthma. If I can't afford albuterol because they're insanely expensive, but my neighbor comes over and says, I'll give you my inhaler for $10, and I buy it, I'm not a bad person. And last major topic is just language that we use. This study that I reference here, you can look up on your own, but it was done Harvard psychology program. They gave 2 cases to hundreds of doctors in the Harvard health system. One case said a patient comes in with fever, chills, sweats, yada, yada, very generic language. One patient said the exact same clinical scenario, but a person with substance abuse. Yeah, there you go. Person with substance abuse versus a substance use disorder. And they got completely different treatment just based on that one word difference. So just by labeling something as a abuser, a substance abuser, makes them get worse treatment. So please use destigmatizing language, non-stigmatizing language, and here are some examples. Never say clean and dirty. When interpreting a drug screen, it is a medical test. It's positive or negative. It's not clean or dirty. It's never someone with fentanyl abuse. It's a person with a substance. Addiction is not a choice or a moral failure, but it's really a response to human suffering. So the real question shouldn't be asked, why are you using why are you a drug addict? Why are you using fentanyl? The real question should be asked, what's pressuring you to feel like you need to numb your life? And then my biggest thing is advocating for access to treatment. So we know Suboxone saves lives. There are huge numbers of people who don't have access to it through legitimate means because they don't have health insurance and they don't have money to afford cash pay clinics who take advantage of people anyways. So as long as it's easier to get fentanyl than it is to get mental health treatment, people are going to continue to use fentanyl. So please, any questions? I think there's a couple minutes. I know it's lunchtime soon. Yeah. Yes, sir. Yes, sir. Yes. There is a lot of investigations into the GLP-1s and how they control cravings for food and increase satiety, and how that translates or bleeds over in some people into cravings for other things, including substances. The data is still out on that. I know there are several studies, some looking at some Manjaro versus some other brands, et cetera. I guess kind of the difference there, but sadly, I don't think it's going to pan out.
I've had people say that the guy was drinking 2 bottles of wine a night, and he comes in and says, I haven't had a drink, I haven't thought about it. So it's anecdotal, but...
Yeah. Worked for that guy.
Well, for all my fat alcoholics.
Yeah, the other downside of that is that, what's the average length that someone stays on a GLP-1? It's about 4 months. So if people could stay on it longer, it would help longer.
Great talk. I've been prescribing buprenorphine since the waiver got removed. And one of the biggest things for me personally was just the initial inertia of just starting. So, the greatest thing that can happen today is, a handful of people leave this room and start incorporating buprenorphine into their practice. What worked for me personally, and I'd love to hear you comment on it, is taking established patients in my primary care practice and taking the patients that I know they're already on buprenorphine being prescribed at an addiction management facility that might be 45 minutes to an hour away, and I'm an easier access point, an easier, more reliable, less barrier of care because I'm 10 minutes from where they live, 15 minutes from where they live. So just taking those patients that are already part of your panel that are struggling with addiction, that their backstory and whatnot, and then incorporating them into your practice and just continuing their current dose of the medication one of the scariest things I think for people starting with buprenorphine is that initial induction that you talked about. And if you're just carrying over their continuity of care, if you feel comfortable prescribing somebody's chronic pain medicine, you should feel comfortable continuing somebody's stable buprenorphine dose. That's just my
Amen.
comment.
Thank you. That's a great recommendation too, because that is so easy. I'll tell you, my primary care residency clinic, the attending there when I was in training, he knew I wanted to do addiction treatment, so he started a panel of Suboxone patients. By the time I graduated, he was like, "These are my favorite patients." Like, there are a lot of reasons. It's simple, it's easy, it's highly billable.
So, quick question for those of you that are prescribing him for you. Are you doing routine drug monitoring with those patients? And if so, what's your approach to the patient who tests positive for things that they're not prescribed?
Yeah, thank you. I left that common question out. I don't know why, but thank you for asking it. Very common. I take a harm reductionist approach. I think harm reduction is misinterpreted sometimes because it's a spectrum. And if you're uber harm reductionist, you can bleed over into enabling of like, hey, as long as you're taking Suboxone, you can do whatever you want. We don't take that approach. We have some behavior modifications we implement if people are continuing to use opioids in particular, right? The Suboxone is for opioid use disorder. If you're taking Suboxone and you're using methamphetamine, that is a separate disorder. You can't punish someone for using meth when they're on a treatment for opioid use disorder. That's like treating someone's high blood pressure and expecting their cholesterol to improve. So we don't give people 30-day prescriptions and say, do whatever you want, who are continuing to use other substances, because there are risks to that. If you're buying meth, you're hanging out with drug dealers. You know, that's a risk. I don't want you to do that anymore. And you told me you don't want to do that anymore by coming to my clinic. So, but we continue the Suboxone, absolutely. The worst thing you can do is stop someone's treatment for their opioid use disorder because they're using meth or they're using cannabis, which is not deadly. Because then you've stopped their treatment for the thing that will kill them today. But we see people more frequently to manage those things. We'll say, come back every week or every 3 days or whatever is needed. Provide more support. Usually ongoing use is not a treatment failure necessarily. It's someone asking for more help. They don't need less help, they need more help.
So I run an MOUD service line in my clinic, and we get a lot of patients who are maybe already established at our clinic or nearby that have chronic pain needs, and they're referred both for chronic pain and because they have OUD, which there is quite a lot of overlap. And we know that chronic opioids are, there's this like vicious cycle where like people feel like they need the opioid, but there's like a physiologic effect that happens, so where it actually makes your pain worse. Mm-hmm. And I was just wondering if you could speak to like maybe the benefits of something like Suboxone for someone with chronic pain in that cycle.
Absolutely, absolutely. You referenced something called opioid-induced hyperalgesia, and that's just sort of like a tolerance your body. Pain is necessary for survival. If you step on a nail, you need to know it, or else it'll just get infected and your foot will rot off. So if you numb all your pain all the time, your body just increases the sensitivity to pain, and so on and so forth. The way opioids work, full opioids, it leads to chronically needing to increase the dose because of tolerance. Well, Suboxone has the ceiling effect, and just by the nature of the molecule, it is more resistant to opioid-induced hyperalgesia. It's resistant to tolerance and constantly needing more. So someone on a stable dose of Suboxone might be stable on that dose indefinitely. Whereas if you get someone stable on a dose of oxycodone, in 3 to 6 months, they're going to be on a higher dose, guaranteed, because you lose effect due to tolerance. But Suboxone or buprenorphine is resistant to that effect. Buprenorphine without the naloxone has a bunch of different brand names, and it's dosed differently, but it is FDA approved for chronic pain management. And it is absolutely wonderful, and people don't really use it a lot because a lot of insurances don't cover it or this or that, but I have a billing code that I use a lot, which is opioid use disorder chronic pain overlap syndrome. I made it up. but it's a real thing. But that title, you know, I made up, but it's real, where you can use Suboxone for opioid use disorder and chronic pain, but you dose it a little bit differently. Lower doses are usually needed and more frequently. But there's a lot of benefits to it, absolutely.
There's a new pain medication on the market. You're an addict.
Mm-hmm.
It's amazing.
Really?
I'm on it.
Nice.
Yeah, I got it. And it's
Non-opioid, yeah.
non-addictive. It blocks the sodium channels in peripheral vein fibers.
Yep.
And look it up. It is incredible for chronic pain with no addiction to dental. It's also $450 a month.
Exactly, yeah. Yes, sir.
I guess one of the, I won't say common, but one of the not uncommon situations that we see sometimes are patients that come in with legitimate acute pain on Suboxone.
Yeah.
I guess how, you know, they break an ankle, they perfed a bowel, you know, what have you.
Yep.
I think there's an unfair stigma kind of, you know, put on those people just because of the fact they're already, you know, on that. But I guess what's the strategy? You wanna help them out.
Yeah, absolutely. Thank you for asking this question. It is a common question for inpatient management. So whether it's going to surgery and you're going to need pain control, or yeah, you break an ankle, you're in the hospital, but you're on Suboxone. This is kind of my visualization of that. I don't know which side you can see, but someone on an average dose of Suboxone is somewhere around here. There are a lot of mu opioid receptors in their brain that are still available, okay? So adding an oxycodone to someone who has a broken ankle is absolutely appropriate. And it's absolutely appropriate to continue their Suboxone as well, because that is their baseline opioid need. If you stop their Suboxone, now you have someone in acute pain and opioid withdrawal. So you're trying to manage their opioid withdrawal with more oxycodone more frequently, when really you could just keep them on their Suboxone and use much less oxycodone for their acute pain. Full opioid when someone's on Suboxone, you absolutely can.
I have a quick question. It'll, I guess, be the last one or 3 minutes after.
Yeah.
Do you see the same barriers of initiation with
Version risk of Suboxone. And it's a lot easier to start. The barriers that I see are just cost. So a Sublocade is a once-a-month buprenorphine injection. Great option. $2,000 a shot. Suboxone film's about $2 a film. So you can do the math on, you know. But if someone has insurance, which I don't see anybody with insurance, so I don't know. But yeah, that is one of the agonist type treatments, replacing one for another, that hasn't panned out to be effective. We use things like Wellbutrin or even Topamax, other things for stimulant use disorder, which is evidence-based treatment. Adderall doesn't have the evidence to support it yet. That, because otherwise you're just under-treating someone's ADHD.
Thank you, Dr. Alexander.
Thank you. Thank you all.
So at this time, please help me welcome Dr. Natalie Freeman, who is the Assistant Dean of Research at LMU-DCOM, and she will present the winners of the poster competition before we adjourn for lunch.
Good afternoon. I know you guys are starving, so I'll make it quick. But we have a lot of individuals that are in the lobby that I'm going to welcome in, if they will. So the alumni have been gracious in allowing our students, faculty, residents present at the 9th Annual Essentials of Clinical Medicine. So before we begin presenting the awards, I want to acknowledge the mentors, the preceptors who have guided their research endeavors. Your dedication to excellence in the medical education and research makes this all possible. The first award is in the student award category. You guys are going to have to come in to receive your awards. Sorry, they're all in the back. So the first winner is the predictive value of perivascular fat attenuation index and risk stratification for major adverse cardiovascular events. And that would be student Dr. Patel of LMU-DCOM Knoxville, if he'll come up to receive his award. This research demonstrates innovation in cardiovascular risk assessment and represents the pursuit of better patient outcomes. Student Dr. Patel, you are receiving a certificate.
Thank you.
And a fake $100 check. It will come in the mail.
Thank you.
Next up is our resident award. So you just had a talk on this, optimizing buprenorphine use in East Tennessee hospitals, a literature review of strategies. Dr. Agwoki, so this timely research addresses the critical healthcare challenges in our region and exemplifies the commitment to evidence-based medicine. She's here. She's here. This young person has truly dedicated a year to being a osteopathic scholar. Extremely proud of her. Pain in the gut, abdominal pain, and a Division II NCAA athlete. It's a case study that demonstrates the integration of osteopathic principles in addressing complex clinical presentation. Student Dr. Sydney Clark. Which would you like first? The check or? Do it together?
Yes, that'd be better.
Congratulations. The last award before you guys get to go to lunch is the Physician Preceptor Award. It is the implementation of AI strategies for rural hospitals, bridging the gap in healthcare. Dr. Pajui, the forward-thinking research addresses the critical need for technology advancement in rural healthcare settings. Please come and accept your award. I think he has some high school students as well. Oh, they did the work, okay. You wanna hold it? Yeah. You're gonna have to come around for the award. There you go. Thank you. Oh, I'm sorry. Congratulations to all of our winners. Oh, you're here. Okay. Dr. Ugolke, congratulations.
Thank you so much.
Thank you. Oh, we'll take that one back. Oh, you didn't get it. Okay. Do-overs. Sorry. Thank you. Sorry about that, you guys. So all of the posters are going to be found down the hallway and into the small room. These students, residents, preceptors have worked so hard. Thank you to the alumni, preceptors, and mentors for allowing us to be here today. Have a good lunch.